Okay, everyone. So welcome to your day 5 of the crisp revision for your Part 1 exam. And I hope you're all enjoying what we are putting forth for you. And I hope it benefits you in a big, big way. Okay, so today we are going to be discussing physiology. And physiology is a very important module as far as Part 1 is concerned. And it is also very interesting because we're going to be discussing what changes happen in pregnancy. And like I always say, when we were doing our MBBS and our PG, etc., that time the focus was not so much on understanding it. But now when you're understanding it, it will become even more, clearer for all of you. So let's begin without wasting any much more time. Okay, so first we begin with the most important cardiovascular and respiratory physiology and about some general physiology as in cell transfers, etc. So we will be covering cell physiology and membrane transport, cardiovascular physiology, pregnancy cardiovascular changes, respiratory physiology, and pregnancy respiratory changes. Sorry. Yep. No. No. Okay, now the cardiovascular changes, the respiratory changes, all of these are very hot topics, as we are calling them, because they are very frequently asked and very, very important weightage in the exam. Now, I had forgotten to tell you yesterday, but the stars that we can see in the corner of our slides. Why isn't my laser working now? Just a minute. Okay, so I hope you can see my laser pointer because today I'm not going to be able to draw. Okay, so these stars on each slide or on each module introduction, it means the weightage that this topic carries in the exam. So nothing we've given less than 3 stars because everything is important, because sometimes we say that, this thing is trivial, but that information is actually very important. So this is also an important slide. And this is talking about cell physiology and membrane transport. Now, we all know that each cell is surrounded by a membrane. Okay, and there are solutes, there are electrolytes which have to travel inside and outside the cell, okay, through the cell membrane. So there are various ways that transfer can happen. So the most common and the most economical way, as we can call it, is passive transport, which does not require any energy. Okay, so this is like spraying a perfume in one corner of the room and then everybody else can actually sniff it. So the perfume is actually diffusing through the air because it is more concentrated on you and it is diffusing to the areas where it is not concentrated. So that is a passive example. That's an example of passive transport. So passive transport involves simple diffusion because the membranes are lipid soluble. So oxygen, carbon dioxide, steroid hormones, these are the molecules which can travel across the cell membrane by simple diffusion. Then we have what we call as the facilitated diffusion. So facilitated diffusion is also passive because it does not use up any energy, but it is going to require a channel or a carrier, like the GLUT2 carrier is involved. Okay, so this is facilitated diffusion, and facilitated diffusion you can see in the sodium and glucose transport also across the intestine. Then, of course, there is osmosis. Okay, osmosis is, like we all know, it is the water moving from area of high concentration to area of low concentration. Okay, so across the concentration gradient. Then let's come to the ATP dependent transport, which is called the active transport, because this is now going to utilize energy. Okay, so in passive transport, we had simple diffusion, which was like everything moving freely. Okay, then we had facilitated diffusion, which is like a gate okay, there's a gate and the products are allowed to move, but through a restricted entry. And of course, osmosis is about the water. Now, in active transport, there is some energy involved. There's a toll involved in crossing, okay? So ATP is the usual form of energy that is utilized. And the most common, the very, very important exam tested area is the sodium potassium ATPase. Okay, so that is an example of primary active transport. And in sodium potassium ATPase, which is important for your action potential, it is 3 sodiums will move out and 2 potassiums will come in. When I talk about the action potential, I'll talk to you about the sodium and the potassium. Now, the secondary active transport is the sodium glucose SGLT and the sodium calcium exchanger. The sodium calcium exchanger is also present in the cardiac myocytes, and it is responsible for the plateauing in the action potential of the cardiac action potential. Endocytosis and exocytosis are also examples of active transport, but these are for larger molecules like immunoglobulins and bigger vesicles or neurotransmitters like that. Okay, so endocytosis is something moving in the cell and exocytosis is something coming out of the cell. So like immunoglobulins, they are taken into the maternal system and then that is endocytosis, and then carrier mediated, there is an exocytosis process through which the immunoglobulin G is transferred to the fetus. Now, coming on to a little bit about the action potential, because that is what will involve all of these sodium potassium ATPase very importantly. So we'll talk about it in detail. The resting membrane potential. Now, I hope you all know the most abundant extracellular cation is sodium, and inside the cell it is potassium. Now, because there's a lot of sodium and a little bit less potassium, and sodium is like, although there's just one plus, but the sodium makes the outside more positive and inside the cell it is negative. Okay, so the cell is negative inside. The resting membrane potential of an axon or a myocyte is actually negative. For an axon, it is around minus 70 millivolts. Okay, so you can imagine a cell, inside it is negative, outside it is positive. Okay, then we have channels. So we spoke about passive, we spoke about active. Passive is where there is a sodium leak happening. So the sodium from outside, because of the concentration gradient, it is coming slowly inside. And because the potassium is more inside and less outside, so it is also leaking out through what we call as the potassium channels. Apart from these channels, which are allowing passive movement of these ions, we also have voltage gated channels. Okay, so these voltage gated channels are the ones which are actually going to cause the depolarization and then the repolarization in the action potential. So first, there will be diffusion of a little bit of sodium, which will come inside. And once it reaches a threshold level, the threshold level is minus 55. Okay, so first it is minus 70, which is the resting membrane potential. Then it reaches minus 55. Only once it reaches this threshold level will the action potential actually get initiated or triggered. And once it gets triggered, then the sodium gated, the voltage gated channels will actually open up and the sodium will pour down into the cell, making the cell inside more positive. So it is going to become depolarized. Okay, so let's just go through this. In the next page, I have a diagram, so I'll explain that also. So the action potential phases are depolarization, where the sodium is coming into the cell through the voltage gated channels. Then after that, once the cell becomes positive and the action potential has reached somewhere around either 0 or plus 30, then there is opening up of potassium channels. Then the potassium channels, the voltage gated potassium channels open up, and the potassium, because they have to maintain balance, potassium will start moving out of the cell and the membrane potential will come down. It comes down to normal, but the cell is not satisfied yet. There's a potassium leak channel which is also there, and the potassium keeps effluxing. It keeps going out. So there is a time of hyperpolarization. Okay, so this is very brief. This is when the potassium is moving out excessively. And following that, there is a period of refractory period, as we call it. So there are absolute refractory period and there's a relative refractory period. Absolute refractory period is when no stimulus will initiate another action potential. Okay, and relative refractory period is when a stronger stimulus can produce an action potential, whether it will be strong or mild, that is dependent upon the stimulus. Now, why is this important? So that the body doesn't go into a tetany. It doesn't have fasciculations, okay? Tremors don't happen. So that is why there is a resting phase, there is a refractory phase. In the cardiac myocytes, as we will see in the next slide, there is a plateau phase. Now, why is that plateau phase important? Because the ventricle has to contract and send the entire blood into the circulatory system. If suppose there was no plateau phase in the cardiac system, then if it was the same as the nervous system, then it would be fluttering. Okay, the heart would not be able to contract enough to send the entire amount into the circulatory system. And so over here in the plateau phase, we have the calcium channels, the L-type calcium channels. These are the long-acting type calcium channels or the lazy type calcium channels, because they open up later and they open up for a long time, and the calcium keeps coming into the cell, so that plateau phase comes, okay, where the heart is contracting. This prevents tetany of the heart. Now, talking about smooth muscles like that are present in the gut and the uterus. So they also are not entirely dependent upon the nervous system for their action. They also have some inherent actions within them. Okay, so they have some pacemaker activity happening within them. And so in the uterus and the gut, so when the uterus is contracting or the peristalsis is happening, it is also some inbuilt pacemaker which is triggering these action potentials within the uterus and the gut. In skeletal muscles, so first the axon has transmitted to the end of the nerve, axon. Then the acetylcholine is released. The acetylcholine will go and attach, and it will initiate the T tubules to trigger dihydropyridine, these receptors to get activated. These dihydropyridine receptors are voltage sensitive. Okay, so because of the acetylcholine, because of the activation of the T tubules, the DHP receptors will get activated. The DHP receptors further are mechanically connected to the R-ryanodine receptor, which are present over the sarcoplasmic reticulum. Then these RYR receptors are activated. These will cause the sarcoplasmic reticulum to release calcium, and this calcium is going to act on myosin and then cause contraction. Okay, so this is about the skeletal muscles. Then about the synaptic junctions. Okay, this is important because we are talking about passive and active transport. So once the action potential reaches the synaptic junction, there is opening up of voltage gated calcium channels, and the calcium will come inside the axon, okay, inside the synapse. And over there, it will trigger the acetylcholine. It will form vesicles of acetylcholine, and they will merge with the cell membrane, and there will be exocytosis of acetylcholine. And this acetylcholine will then act on the various tissues. So calcium is very important for neurotransmitter release. So all in all, one very important point over here is that the sodium potassium pump has 3 potassium going out and 2 potassiums coming in. And this gradient is what is going to drive most of the secondary transport. Okay, so on the left over here, this is the action potential which we see in the nerves. or also in the muscles, okay, the normal muscles. So like I said, the resting membrane potential is minus 70, okay, because of the sodium coming in, it will become a little bit more positive, okay, so minus 55 is more positive than minus 70. This is the threshold. If it does not reach minus 55, it will be failed, okay, so it will go up, but it has not reached minus 55, come down back again, go up, not reach, come down back again. But once it reaches minus 55, this is the point of all or none, okay, so an action potential is all or none. Either it will go or it will not go, okay, so here if it reaches minus 55, the sodium, I told you about the voltage gated sodium channels, they will open up, lot of sodium will come in, so this depolarization will happen, okay, so this depolarization is due to massive sodium influx. Now once it reaches a potential of 30 millivolts, okay, that is the time that the voltage gated sodium channels will shut and the voltage gated potassium channels will open up. Now we said that the potassium is intracellular. So now once the voltage gated channels have opened up and there's a lot of positive ions within the cell, so the potassium channels will open up and the potassium will go out. So bringing back the membrane potential a little bit towards the negative side. Now, this is where the sodium potassium ATPase comes in. Once the action potential is over, we have a lot of sodium inside and we have a lot of potassium outside, which is not what is physiologically happening. There is, the sodium has to go out and the potassium has to come in so that the next action potential can take place like this. So this is where the sodium potassium ATPase comes in and then it sends out 3 sodium and brings in 2 potassium. So this is where the sodium potassium pump or the ATPase, it will come in, okay? Right. Now coming to the right side of the diagram, the right side diagram, this is about the cardiac myocytes. Again, there is a resting membrane potential. Then the voltage gated sodium channels will open up and the sodium channels, it will cause depolarization. Okay, once the depolarization has happened, then the sodium channels will close and the potassium channels will open up, but there's a transient opening of the potassium channels and the potassium will come start moving out, so it will get little bit of repolarized, but before it can come back to its resting membrane potential, the calcium channels decide to open up, thankfully, okay, and the calcium will start coming inside, okay, so instead of the potassium flowing out too much, the calcium starts coming inside, thus maintaining the positivity of the intracellular membrane, okay, and then this plateau phase will happen, and once the plateau phase, the contraction is over, it is time for the membrane to come down, so the calcium channels will close and the potassium channels will then open up, and then the potassium channels will efflux and the membrane potential is reached again, okay. So this is about the action potential of the nerves, and this is the special thing about the cardiac myocytes is about the calcium, okay. There is an SA node in the heart, and in that SA node, the peculiar point about the action potential is that there is no hyperpolarization, okay. So that the membrane comes back to normal, then it will again pick up, okay. So we cannot have the refractory period there. All right. Okay, so just a little bit of recall about this little topic. Sodium, potassium, ATPase, like we discussed, very importantly, 3 sodiums move out and 2 potassium comes in. This is at the end of the action potential, okay? Once everything, the repolarization has happened, it has come back. Now to maintain the homeostasis, the sodium, potassium, ATPase will function and 3 sodium ions will go out, 2 potassium will come in, okay? Then we have the GLUT2, which is insulin dependent, and it is a form of facilitated diffusion. Then we have GLUT4 or GLUT4, which is again insulin. This GLUT2 is insulin independent and GLUT4 is insulin dependent. Okay, and this is present in muscles and fat. We spoke about the resting membrane potential, which is around -70. Some physiology books do mention it as -90, but we are going with -70 because those are from the books which are prescribed by the RCOG. Depolarization, the initial phase, the initial up phase is when the sodium is coming in. Sodium is usually extracellular, but when it comes in, it is building up the action potential, and that is the depolarization phase. Repolarization is when the inside of the cell has become very positive. It has to come back to its resting membrane potential. So what will go out? The potassium will move out. Okay. Then, of course, the cardiac plateau is due to the L-shaped calcium channels, and in that the calcium will come in. The plateau is very important to prevent tetany and also to help the heart contract fully and eject its full fraction. Steroids cross the membrane by diffusion. They are lipid soluble, and endocytosis is vesicle uptake, and exocytosis is when the vesicle is let out. Okay, so these are important part of cell physiology and membrane transport. Okay, now let's talk about the cardiovascular physiology. Okay, so the cardiac cycle, let's look at the heart. The main thing in the heart are the ventricles. So what does the ventricle have to do? It has to fill up. First, it fills up, then it has to contract. And once it contracts and builds up the pressure, then it has to eject the entire amount into the circulatory system, into the aorta and the pulmonary system. And then it has to again relax and then refill. Okay, so it starts from filling, contraction, ejection, and then refilling. Okay, so this is the cardiac cycle in brief. And let's talk about the left ventricle. So first, the atrial systole will happen. Atrial systole is when the ventricle starts filling. Okay, so the mitral valve is open, the tricuspid valve is open, and the atria is contracting. Okay, and this is the P wave. Okay, the atrial systole is represented by the P wave. After that, the mitral valve, once the atria has emptied, okay, the atrial systole is actually the last bit. Okay, first it is just flowing down because the ventricle is empty and the atria is emptying itself into the ventricle. Then the last little bit of blood which is left in the atrium, the atria is going to contract and let it out into the ventricle. So this contraction of the atria is going to cause the P wave. This is the atrial systole and the P wave. Now, once the atria is emptied, the mitral valve and the tricuspid valve will close. And as we are going to read up over here, this is going to produce the first heart sound, and this is the beginning of the systole of the ventricle. So atrial systole is by that small P wave, which is absent in atrial fibrillation. Okay. Then now imagine the heart is there, the mitral and tricuspid have closed. The semilunar valves or the aortic valve and the pulmonary valve, they are also closed. Okay, so this is the ventricle, and this is now going to build up pressure. Okay, so this is not going to increase in volume. It's not dilating. It's not increasing in volume. It's not undergoing any hypertrophy as yet. Okay, if there's a pathology, only then it will happen. So with the mitral valve closed on top and the aortic valve closed in the bottom, I mean, I'm just talking schematically. Okay, the ventricles are going to contract. So this is the isovolumetric contraction or the QRS wave that we see in the ECG. Okay, so mitral valve is closed and the semilunar valve or the aortic valve is also closed. Okay, at the end of this isovolumetric contraction, when the pressure of the ventricle supersedes the pressure in the aorta, the semilunar valve will open and there will be a rapid ejection. Okay, so like like in the atria and the ventricle is now going to push the blood out into the aorta, and right side it will go into the pulmonary system. Okay, so the semilunar valve will open. And after the pressure has reduced, okay, so most of the blood has gone out, then again, that little bit of blood, okay, that is there, and we need the blood to come out into the circulatory system as much as possible. So then there will be a little bit of ventricular contraction again, and that is your T wave, okay? So the T wave is again, the ventricular contraction. And after the ventricle has emptied itself, so it is empty, and the S2 will happen. The second heart sound will happen because of the semilunar valve closure. Okay, so the AV valves will close, and this will begin the phase of isometric relaxation. So the semilunar valve will close, the mitral valve are already closed, so now the heart will relax. The atria will build up pressure. Okay, once that pressure is enough, then the mitral and the tricuspid open, and this is what is the cardiac cycle. Okay, the heart sounds, like we spoke about, the S1 is when the mitral and tricuspid will close, and this marks the beginning of systole or systole. And then we have the S2, the second heart sound, which happens when the semilunar valve will close or the aortic and pulmonary will close. This marks the end of systole. And in some patients, in some physiological conditions like normal patients, young patients or pregnant ladies also, or pathologically it is present in heart failure, there is a rapid ventricular filling, and that produces S3, the third heart sound, which is like gush sound. And the S4 is when the ventricle has to push against a lot of resistance. Okay, so the ventricle has to eject against a lot of resistance, and this is when there is hypertension or aortic stenosis. Okay, so this is in brief about the cardiac cycle. All right, so what is cardiac output? How much blood does the heart have to pump? So that is a product of the heart rate and the stroke volume. So at rest, a normal cardiac output is around 5 liters per minute, and the stroke volume is around 70 ml. Okay, so the cardiac output is a product of both of these factors. What is the preload? So preload is the end diastolic volume. End diastolic volume in the sense before the filling stage, the ventricles, the fibers length, that is the end diastolic volume. And according to the Frank-Starling principle, more filling, more contraction, more the heart will be able to eject better. Okay, so that is the Frank-Starling principle. Afterload is, of course, the resistance against which the ventricle has to pump, and more the afterload, more the load on the heart, and it is going to be pathological. Okay, what is the blood pressure? Blood pressure is the product of cardiac output and systemic vascular resistance. And the most important of all of these factors, which is going to actually tell us whether the organs are well perfused or not, is the mean arterial pressure, or the MAP, and that is deduced by diastolic blood pressure plus 1/3 of the difference between the systolic and the diastolic blood pressure. For example, if the BP is 120/80, then the mean arterial pressure will be 80 plus 1/3 of 120/80, that 120 minus 80, which is 40, which is around 13. So it will be 80 plus 13, 93. So in 120/80, which is the normal average blood pressure, the mean arterial pressure is around 93. And we have to know that the mean arterial pressure of more than or equal to 65 millimeters of mercury is required for organ perfusion. If it is less than that, that means the organs are hypoperfused. Now, how is the BP regulated? So it is regulated through baroreceptors, then the RAS system, the ADH, and also the sympathetic nervous system. So how do the baroreceptors act? They are short-term. Okay, so they are in the carotid sinus and the aortic arch. As soon as the BP falls, they are activated, and then they will be stimulating the nervous system to cause the BP to increase, the heart to contract more and the BP to increase. What is the RAS system? So suppose in the long term, the BP, suppose it's continuously, it is low, then the RAS is activated. So the juxtaglomerular cells, they will secrete renin, then the angiotensin 1, angiotensin 2, and aldosterone, and then the BP will come back to normal. ADH is secreted from the posterior pituitary, and this is an anti-diuretic hormone, so it prevents the diuresis. It will cause water retention. It will build up the volume, blood volume, and therefore it will build up the blood pressure. And the sympathetic nervous system acts through the alpha-1 vasoconstriction and beta-1 inotropy. Okay, so the cardiac output formula is heart rate into stroke volume. BP is cardiac output into the systemic vascular resistance. Mean arterial pressure is diastolic blood pressure plus 1/3 of the difference between the systolic and diastolic blood pressure. Okay, so a little bit recall. Cardiac output we discussed, heart rate into the stroke volume, which is around 5 liters per minute, the normal cardiac output. Mean arterial blood pressure. A mean arterial pressure is diastolic blood pressure plus 1/3 of the difference between systolic blood pressure and diastolic blood pressure. I told you about 120/80. It comes out to around 93. BP is product of cardiac output and systemic vascular resistance. S1 is when the AV valve or the mitral and tricuspid close. S2 is when the aortic and the pulmonary valve close, which is the semilunar valves. S3 is produced in the early diastolic filling stage. Pathologically, it represents heart failure. S4 is the atrial kick. It happens when the ventricles are stiff. Preload is the end diastolic volume. Afterload is dependent on the systemic vascular resistance. So if there is aortic stenosis or hypertension, then the afterload will be high. Baroreceptors are there for short-term BP control, and the RAS and ADH are for the long-term BP control. Okay. All right. Again, a little bit more. So in pregnancy, the cardiovascular system adapts according to the requirement of pregnancy, and the pregnancy has a baby growing inside, so it has to support the placental and the fetal circulation. So the plasma volume will increase by 45 to 50%, and it peaks at around 32 weeks. The RBC mass will also increase, but it will only increase by 20 to 30%. So there's a lot of plasma volume which is increasing, but not as much of RBC. So there is hemodilution, there's physiological anemia, there's physiological hemodilution or dilutional anemia in pregnancy. The net effect is physiological anemia. The hemoglobin will drop around 10 to 20 grams per liter. Okay. Please understand this is grams per liter, not milligrams per deciliter. Cardiac output increases by 40 to 50%. The heart rate increases 10 to 20 beats per minute at rest. Stroke volume will increase by 25 to 30%. It will peak at 24 to 28 weeks. There is further increase in the cardiac output during labor, and it is around 15% per contraction. But the maximum cardiac output is after delivery, immediately postpartum, and it is around 60 to 80% above the baseline. And this is why in a heart patient or an anemic patient, okay, the most critical period is also in the postpartum time, okay, immediate postpartum. Systemic vascular resistance will decrease by 30% because of the progesterone, the nitric oxide, and the prostacyclin-mediated vasodilatation. So the heart rate goes up, the plasma volume goes up, the cardiac output goes up, but the peripheral vascular resistance and the diastolic and systolic BP, they will come down. Okay. So in the BP there is minimal change in the systolic BP, or it can come down unless and until, of course, there's a pathological happening and the preeclampsia happens. Then, of course, diastolic will reduce by 5 to 10 millimeters of mercury by mid-pregnancy. The lowest BP is around 16 to 24 weeks, and it rises back near term. Aortocaval compression, this is the supine hypotension syndrome. So after 20 weeks, the gravid uterus is weighing on the inferior vena cava and the aorta. That is why you recommend that the patients will lie on their left side or even on the right side, but more on the left side, so that the pressure over the aorta and the inferior vena cava is relieved. Okay. So because of the pressure, if they don't lie supine, there will be reduced venous return. The cardiac output will therefore be decreased. Mother will have hypotension and the baby will go into distress. So whenever we take a patient for cesarean, the anesthetist put a wedge on the left side of the patient. So that is giving a left lateral tilt so that the gravid uterus is not weighing on the aorta and the inferior vena cava. For the same reason, the postpartum, the peripartum, this postmortem cesarean section is done. Okay. So it is an attempt to resuscitate the mother. Okay. After 20 weeks, if a mother collapses and she's not, responding to the normal methods, then in 4 minutes, you're supposed to decide. And in 5 minutes, the baby should be out. Okay. So that the uterus does not weigh on the inferior vena cava anymore, and your CPR can have more fruitful, productive results. Then murmurs in pregnancy, around 90% of patients may have murmurs. These are the systolic ejection murmurs or mammary souffles. ECG will show left axis deviation in pregnancy, and there will be inverted T waves in the third lead, and the ectopics are also commonly seen. Postpartum, the cardiac output will peak immediately because there is, again, relief of the inferior vena caval compression, and therefore there will be an increase in the venous return, and also auto transfusion from uterine contraction, which is around 500 ml. And that is why you do not give ergometrin in anemic patients, in heart patients, because you're not wanting more of these uterine contractions to push a lot of blood into the system, because the patient can go into heart failure. Okay. So just a little bit in this slide. So the cardiac output, it rises rapidly from 8 weeks, peaks at around 24 to 28 weeks. Then it will plateau, and then near term, it will come back to little bit back to normal. Plasma volume is peaking at 32 weeks. Diastolic BP, the nadir, the lowest one, is around 16 to 24 weeks and returns to baseline at term. Peak cardiac output is immediately postpartum. So amongst the phases, okay, it's at 12 weeks, then at 24 to 28 weeks, then in labor and postpartum. So these are the times in pregnancy when the lady can be maximally compromised. Okay. So after delivery, the IVC compression is relieved, and also because of the uterine contractions, there's auto transfusion into the system, and therefore the cardiac load is increased, and the patient can go into heart failure if she is predisposed to such conditions. Aortocaval compression after 28 weeks in supine position, we discussed this. The gravid uterus will compress the IVC and the aorta. Because of that, there will be reduced venous return, decreased cardiac output, maternal hypotension, and fetal compromise. And the management is 15 degrees left lateral tilt or manual uterine displacement. Okay. The plasma volume will increase by 45%. Cardiac output is around 40 to 50%. Heart rate is 10 to 20 beats per minute. And the systemic vascular resistance will decrease by around 30%. Plasma volume, like we again said, it is increasing by 45 to 50%. The peak is at 32 weeks. RBC mass will increase by 20 to 30%. It is less than the plasma. So there is physiological anemia. The hemoglobin will drop by 10 to 20 grams per liter. The cardiac output will increase by 40 to 50%. It peaks at 24 to 28 weeks. Heart rate increases by 10 to 20 beats per minute. the systemic vascular resistance will fall by 30%. Diastolic blood pressure is going to fall, and the lowest is going to be around 16 to 24 weeks, and near term, it is going to come back to normal. There is an element of aortic cable compression after 20 weeks. That is why clinically we tell patients to lie in the left lateral position. Okay. And then if you're resuscitating the patient, or if she's lying down, at least you have to tell her to put a pillow on the left side. So a left lateral tilt of 15 degrees is helpful in managing supine hypotension. And postpartum, the cardiac output is at its peak. It will come back to normal within 24 hours, but immediately postpartum, it is at its peak, and it's a very critical period for patients predisposed to heart failure. All right, coming to the respiratory physiology. So lung volumes are a frequently asked and a favorite question of the examiners. So we need to know what are the lung volumes which are going to increase in pregnancy, what is going to decrease in pregnancy. But before that, we need to know what is the normal lung volume. Okay, so tidal volume is when we take the normal breath. Okay, so that is around 500 ml per minute. Inspiratory reserve is around 3000 ml. Expiratory reserve is 1100 ml. Residual volume is the volume of air which stays in the lungs after maximal expiration. So that is around 1200 ml. Vital capacity, and these formula are very important. Okay, so the vital capacity is tidal volume plus inspiratory reserve volume plus expiratory reserve volume. Okay, and that is around 4.6 liters. Total lung capacity is the vital capacity plus the residual volume, which is around 5.8 liters. And the functional residual capacity is expiratory reserve volume plus the residual volume, which is around 2.3 liters. The residual volume cannot be measured by spirometry, and it needs helium dilution or plethysmography. FEV1 by FVC ratio is less than 0.7. This implies that the patient has some obstructive respiratory disorder like asthma or COPD. If the FEV1 is normal or raised, then it could be a restrictive pathology like fibrosis or kyphoscoliosis. Now, we'll just discuss what these volumes are and what happens in pregnancy. Okay, so the lung volumes which increase in pregnancy, the mnemonic is I see movie in TV. So inspiratory capacity will increase, movie, so minute volume will increase, in is nothing, and the tidal volume will increase. So these are the lung volumes which are going to increase in pregnancy. So this is a normal spirometry chart. So if you take a deep breath, okay, and then you exhale to the maximum. So take a deep breath and exhale to the maximum. So that is represented by these 2 points. Okay, these 2 points. Okay, so this is, what is this? This is your vital capacity. Okay, so this is vital capacity. Maximal inspiration and then maximal expiration. So the area between them, this is your vital capacity. Okay, and what is the remaining air which is inside the lungs? That is your residual volume, and vital capacity plus the residual volume. So this is your total lung capacity. Okay. So this is residual volume, the remaining air in the lungs after maximal expiration, and vital capacity plus the residual volume. That is your total lung capacity. Okay. This is tidal volume. Okay. This is the volume of air that we are breathing normally in a minute. Okay. So this is your tidal volume. So then if you remember this diagram, you will be able to understand all those formulae that were asked, and the exam, it will become easier. Okay. So just remember this, then you'll know that between the tidal volume, okay, and the maximal expiration, this is the expiratory reserve volume. Okay. And this plus the residual volume will be your functional residual volume. Okay. So this is how you memorize a spirometry chart graph, and just a little bit more about what volumes will go up what will come down, and which will not change. So this is your chart for that. What will go up is IC movie in a TV. So inspiratory capacity, the minute volume, and the tidal volume, they will go up. The PaO2 also goes up. The oxygen potential will increase, and the arterial pH will also increase. And what comes down? The carbon dioxide, the functional reservoir capacity, and the airway resistance. And the other factors do not change. Okay. All right. Talking about gas change in a normal person. So alveolar PO2 is 100 millimeter mercury because alveoli are getting all the oxygen. And the PCO2 is 40 millimeters of mercury. Arterial PO2 is 95 millimeters of mercury, and the PCO2 is around 40 millimeters of mercury. And the alveolar arterial gradient, this is very important. The alveolar arterial gradient is normally less than 15, okay, and that is important so that the oxygen can flow from the alveoli to the arterioles, okay. So that is why the gradient is there. And as the age increases, there is some amount of, ventilation perfusion mismatch. So the alveolar arteriolar gradient, it will rise with age, okay. Then talking about this oxygen dissociation curve, it is sigmoid in shape, as we can all see. What will happen when the curve is shifted to the right? It is shifted to the right in what conditions? Increased carbon dioxide, reduction of oxygen, increased temperature, and in acidotic conditions. In these conditions, the curve, the oxygen dissociation curve, moves towards the right. And what does it mean that it moves towards the right? That means it will release the oxygen, okay? It will release the oxygen to the tissues. And this is your basis of Bohr's effect, okay? So Bohr's effect is happening in the organs. BO is happening in the organs, and in the organs, because of the metabolism, there is increased carbon dioxide, so the oxygen pressure is low, and because of the metabolism, the temperature is high and acidotic, so the oxygen dissociation curve moves towards the right and gives off all the oxygen to the tissues and takes up carbon dioxide. On the other hand, when it goes to the lungs, okay, in the lungs, the alveoli have high oxygen pressure, their CO2 is low, and they are not in an alkalotic state. So the curve will now shift towards the left. Okay, when it shifts towards the left, that means it will take up more oxygen from the lungs. Okay, this is the basis for the Haldane's phenomenon. So the right shift means it has reduced affinity for oxygen. Okay, reduced affinity for oxygen. And these are the conditions where it will move to the right. If the 2,3-DPG is increased, temperature is increased, there is acidosis, and there is reduction of oxygen. So it is happening in the peripheral tissues or the organs. Left shift is when the carbon dioxide is low, the acidotic or the hydrogen ions are low, so that means it is alkalosis, or in fetal hemoglobin also. And in methemoglobin and carbon monoxide poisoning, the oxygen dissociation curve will move to the left. In fetal hemoglobin, it is because nature is so beautiful. In the fetus, the oxygen dissociation curve will move to the left so that the fetus can maximally take oxygen from the mother. Okay, so this is actually a double Bohr effect because the fetus is taking oxygen on one side, and on the other hand, the mother also is taking oxygen when the blood reaches the lungs. Okay, so this is the Bohr's effect in the fetus. Now, how are these gas exchanges controlled? By central chemoreceptors, which are present in the medulla. These will sense increase in the carbon dioxide ions or the hydrogen ions. Okay, this is an SPA. They have asked that the central chemoreceptors will be stimulated by increase in oxygen, decrease in oxygen, increase in pressure, or increase in hydrogen ions. So the answer there was hydrogen ions. Okay. Peripheral chemoreceptors, which are present, like we spoke about in the BP regulation also, they're present in the carotid and the aortic, and they will sense reduction in the oxygen and then they will get activated and stimulate the respiratory system. Okay. So the right shift is when, suppose a patient is exercising, so there's increased carbon dioxide, a patient, no, a human being, there's increased carbon dioxide, there's increased hydrogen ion, temperature is increased, and there is increased 2,3-DPG, then the curve will shift to the right, and it will give off the oxygen, Bohr's effect. Okay. So the tidal volume is around 500 ml, vital capacity is 4.6 liters, the TLC is around 5.8 liters. Residual volume cannot be measured by spirometry. If the FEV1 by FVC ratio is less than 0.7, then it is implying an obstructive respiratory pathology. If the FEV1 by FVC ratio is normal, then it is implying a restrictive pathology. Bohr's effect is when the presence of increased carbon dioxide in the tissue shifts the curve to the right. The right shift can also happen when there is increase in temperature, acidosis, or increase in 2,3-DPG. Left shift will happen when in fetal hemoglobin, in carbon monoxide poisoning, or in methemoglobin. Central chemoreceptors in the medulla will sense the CO2 and acidosis. Okay, they will sense that. Peripheral chemoreceptors will sense the changes in the oxygenation levels. The alveolar arteriolar, it's not the arteriolar alveolar, it's the alveoli and the arterioles. That gradient is normally less than 15 millimeters of mercury, and which is important for the oxygen to come from the alveoli to the arterioles. Okay, so we spoke about the lung volumes which are changing in pregnancy. So the respiratory changes in pregnancy are driven by progesterone. Okay, so it stimulates the respiratory center and there is increased metabolic demand. So therefore, the tidal volume will increase by 40%, and this is the main change in the lung volume. Respiratory rate is more or less normal. It will stay around 15 to 16 beats respiration per minute. Minute ventilation will increase by 40 to 50%. This is because the tidal volume is increasing. So if in a minute the tidal volume is increasing, so obviously the minute volume will also increase. The total lung capacity, there's hardly any change. Around maybe it is 5% less only. That is because the diaphragm is pushing the lungs up. Vital capacity is unchanged or there is minimal reduction. Functional residual capacity is again decreased by around 20% because the diaphragm is pushed up by 4 centimeters. The expiratory reserve volume and the residual volume, they will both reduce, they will both decrease, and the inspiratory capacity will slightly increase. So I see movie in a TV. Well, about the blood gas changes, the PCO2 is reduced to around 28 to 32 millimeters of mercury. So pregnancy is in a state of compensated respiratory alkalosis. Okay, that is a normal state in pregnancy. The CO2 levels are lower than in a normal ABG analysis. It is around 28 to 32 millimeters of mercury. The PaO2 is slightly increased. It is around 102 to 108. Bicarbonate is decreased to around 18 to 21 millimoles. This is because of the compensation by the kidneys. The pH is slightly alkaline. It is around 7.42 to 7.45. And this is also a compensatory mechanism. Dyspnea of pregnancy. This is common in 60 to 70% of patients. And this is just the awareness of hypoventilation. And it is not exertional. It is not at rest. Okay, this is just the awareness of hypoventilation, and it is different from pathological dyspnea, which is present in preeclampsia and in anemic patients. The diaphragm is displaced up by around 4 centimeters. So the upper rib costal angle will widen. Oxygen consumption is because of the placenta and the growing fetus. It is going to increase by around 20%. And there is reduction in the functional residual capacity. and there is faster desaturation under anesthesia, okay, because the residual capacity is low. So the progesterone is the main driving factor here. It will stimulate the respiratory system. It will increase the tidal volume, which will increase the ventilation and reduce the partial pressure of carbon dioxide. So pregnancy is in a state of either you call it chronic respiratory alkalosis or compensated respiratory alkalosis. Okay, so the tidal volume is increasing by 40%. This is the main change. And because of this tidal volume increasing, the minute volume is also increasing by 40 to 50%. The respiratory rate is unchanged. The functional residual capacity is decreased by 20%, which predisposes the patient to respiratory failure if the patient is anesthetized. Okay, the residual capacity is lowered. The partial pressure of CO2 is also lower than in a normal ABG. We will come to the difference. It is around 28 to 32 millimeters of mercury. Pregnancy is a state of compensated respiratory alkalosis. The compensation comes from the kidneys, and because the kidneys are compensating, so the bicarbs are coming down. Okay, so the bicarbs are around 18 to 21 millimoles per liter. And because of the reduced functional residual capacity, there is faster desaturation under anesthesia. It is progesterone which is driving all these changes, and the diaphragm is moving up by around 4 centimeter near term. Okay, moving on to the SPAs for the first R. Okay. The sodium-potassium ATPase pump moves ions in which ratio? 2 sodiums out, 3 potassium in. 3 sodium out, 2 potassiums in. 3 sodiums in, 2 potassiums out. 1 sodium out, 1 potassium in. 2 sodiums in or 2 potassiums out. So we have discussed this. I have told you this is happening at the end of the action potential. Okay, so the answer is 3 sodiums out and 2 potassiums in. Okay, this is the primary active transport, and this will set up the electrochemical gradient. So once the sodium potassium ATPase is pushing out 3 potassium and bringing in 2 potassium, so there is a relative difference in the potential, membrane potentials outside and inside, and that is why intracellular it is more negative. Okay. The plateau phase of the cardiac potential is due to sodium influx, potassium efflux, calcium influx via the L-type channels, fluoride influx, or the sodium-potassium ATPase activity. I hope all of you will remember this in the exam, and the answer is calcium influx via the lazy type channel. So you can remember them, they're lazy. Okay, slowly they're coming in, slowly they're plateauing the action potential. Okay, this is very important for proper ventricular contraction and to prevent the tetany of the heart. Which heart sound corresponds to atrioventricular valve closure? So mitral valve and tricuspid valve, when they close, what is the sound that they produce? S1, S2, S3, S4, or is it an opening snap? So it is S1. Okay, and S1 is marking the beginning of the systole. Okay, so it is the start of the systole. This is when the AV valve, okay, the mitral and the tricuspid will close at the start of systole. S2 is when the semilunar valves, which is the aortic and the pulmonary valves, will close. S3 is in heart failure when there is rapid ventricular filling. It is also normal in some young people and also in pregnancy. And S4 is the actual kick into a stiff ventricle, which is seen in hypertension or LVF. Okay, so if the ventricle is stiff, the atrium has to pump that P wave that we talked about, the atrial kick. Okay, so that will produce a sound, and that is the S4 sound. Mean arterial pressure is best calculated as the sum of systolic plus diastolic blood pressure divided by 2. So the mean of the systolic and diastolic pressure. Diastolic blood pressure plus 1/3 of the difference between systolic and diastolic blood pressure. Or is it just the difference between the systolic and diastolic blood pressure? Or is it diastolic blood pressure plus 2/3 of the difference between systolic and diastolic blood pressure? Or is it systolic blood pressure 2 times plus the diastolic blood pressure divided by 2? And we have calculated according to 120 by 80. The answer is B, diastolic blood pressure plus 1/3 of the difference between systolic blood pressure and the diastolic blood pressure. And this is a very important pressure to determine whether the organs are getting perfused properly or not. Okay. And the minimum mean arterial pressure should be at least 65. So more than or equal to 65. By how much does the plasma volume increase in pregnancy? 10 to 15%, 20 to 25%, 45 to 50%, 70 to 80%, or there is no change. So it is 45 to 50%. So the plasma volume is increasing by 45 to 50%. The RBC mass is only increasing by 20 to 30%. So this is physiological anemia or dilutional anemia or physiological hemodilution. Cardiac output increases by 40 to 50% and it peaks at around 24 to 28 weeks. Cardiac output during pregnancy peaks at 8 to 12 weeks, 24 to 28 weeks, 36 to 40 weeks during labor only or first week postpartum. So we just discussed it. I hope the short-term memory is good and it stays in the long term. So it is 24 to 28 weeks. The cardiac output rises from early pregnancy. It peaks at 24 to 28 weeks and rises 40 to 50% above the baseline. It plateaus and then dips slightly at term. The absolute maximum cardiac output is immediately postpartum because of autotransfusion and also the inferior vena cava is decompressed. So the aortocaval compression is relieved. Aortocaval compression in pregnancy becomes significant after 8 weeks, 12 weeks, 20 weeks, 32 weeks, or only in labor. Okay, so you have to remember what you tell your patients. If your pregnant lady is coming to you, at what gestation do you start asking her to preferably lie on the left lateral side? So that is around 20 weeks. Okay, so after 20 weeks, the gravid uterus is compressing the inferior vena cava and the aorta in the supine position. There is reduction in venous return. Because of that, the cardiac output will fall. Because of that, there is maternal hypotension, and therefore fetal compromise will also happen, and you manage it by a left lateral tilt by about 15 degrees. Which lung volume cannot be measured by spirometry? Is it the tidal volume? Is it inspiratory reserve volume, expiratory reserve volume, residual volume, or vital capacity? So what is it? It is residual volume. So residual volume cannot be exhaled. So spirometry cannot measure it. That is the volume of air which is remaining in the lungs after maximal expiration. So if that is not going into the spirometer, how are we going to be able to measure it by spirometry? So residual volume cannot be measured by spirometry. It needs helium dilution or plethysmography, and any capacity containing residual volume like functional residual capacity or total lung capacity, therefore they also will require plethysmography because they are not measuring the residual volume. Which causes a right shift of the oxygen dissociation curve? Is it the fetal hemoglobin? Is it the carbon monoxide? Is it increased 2,3-DPG, decreased temperature, or alkalosis? Okay, this is the Bohr's effect. What is happening in the tissues? So what is happening there? There is increased 2,3 DPG. Okay, so right shift will reduce the oxygen affinity of the hemoglobin. Once the oxygen affinity of the hemoglobin is reduced, that means it is giving off the oxygen to the tissues. This is happening when there is acidosis, there is increased carbon dioxide, there is increase in temperature, or there is increase in 2,3-DPG. Left shift is happening when there is in a fetal state, when the fetus needs more oxygen, okay? In carbon monoxide poisoning, methemoglobin, alkalosis, reduction in temperature, and the fetal hemoglobin's left shift helps it to obviously grab more and more oxygen from the maternal blood. Arterial PaCO2 in normal pregnancy is typically 28 to 32, 35 to 45, 46 to 45, 20 to 25, or is it unchanged from non-pregnant state? So we had discussed the pregnancy is a compensated respiratory alkalosis, okay? So it is 28 to 32 millimeters of mercury. So progesterone is stimulating the respiratory system. That will increase the tidal volume. It will increase the minute ventilation. So the PaCO2 is going to fall to 28 to 32. And this is respiratory alkalosis. The bicarbonate, because of the renal compensation, will also fall to 18 to 21 millimoles per liter. So this is comparison in a normal adult, and this is in the pregnancy. So in a normal adult, the pH is 7.34 to 7.44, but in the pregnancy state, a normal pH is 7.4 to 7.46. So in an SPA, which comes in the exam, if you are dealing with a pregnant patient, please understand the pH is going to be, normal pH is 7.4 to 7.46, okay, which in a normal condition you would have called alkalotic, okay, but pregnancy is a state of compensatory respiratory alkalosis. The PaCO2 is 28 to 32 in pregnancy, whereas in our normal ABG analysis, when we do, it is around 35 to 45 millimeters of mercury. The bicarbonate is 22 to 26 milliequivalents per liter in a normal human being and in a normal adult, and in pregnancy, it is going to fall to 18 to 21. Base excess, a normal base excess is -2 to +2 millimoles per liter. Okay, we will begin with our second hour. I'll just take a 2-minute break for just sipping water and getting my lozenge. And if you need a little break, then please take it. I'll just get mine. This is why sessions are very good, because you people read most of the things. Over here, we have to do 3 hours of talking. All right. So let's begin with the second hour, and we are going to be discussing the renal, the gastrointestinal, and hepatic systems, and also a little bit about hematology. Okay, so we're going to be discussing renal physiology and acid-base balance. We're going to be discussing changes in pregnancy in the kidneys. We're going to be talking about hepatic physiology in pregnancy and a little bit about hematology and coagulation in pregnancy. Okay, so again, all of these are actually very important. The acid-base balance, one question is guaranteed in the exam, this way or that. Okay, and I'll tell you which way or what. Okay, let's talk about the renal physiology and acid-base balance. So the normal GFR is around 125 milliliters per minute. And in ladies, it is around 120 milliliters per minute. The filtration depends upon 1, driving force, and 2, opposing forces. So the glomerular hydrostatic pressure is the driving force, and the plasma colloid osmotic pressure and the Bowman capsule pressure is the opposing pressures. Okay. Proximal tubule is where 67% of the electrolytes, the glucose, the amino acids, all of these are reabsorbed. So if in the exam, suppose you're confused where what is getting absorbed and you really don't have any clue, then the safest option would be to go for the proximal tubule. But of course, if you know, then even better. Then in the loop of Henle, there is a countercurrent multiplier, which will create a medullary gradient. In the thick ascending loop, there is what we call the NKCC2 or the sodium potassium 2 chloride co-transporter. And this is where loop diuretics are targeted. The distal tubule is where the sodium chloride co-transporter is present. And this is where the thiazides are targeted. And the collecting duct, this is where the aldosterone will act. So the sodium potassium balancing is happening. And the ADH, the antidiuretic hormone, is going to induce aquaporin 2. And this will help the water to be absorbed. And this is where desmopressin will act. In the collecting duct also, there is the ENaC or the epithelial sodium co-transporter, okay, where the sodium is absorbed, and this is where the potassium sparing diuretics will be acting, okay. And what are the potassium sparing diuretics? The mnemonic is SEAT, which is spironolactone, and eplerenone, which are aldosterone antagonists, and amiloride and triamterone, which are direct epithelial sodium co-transporter inhibitors, okay. Then we have in the juxtaglomerular apparatus the macula densa. If there is reduction in sodium chloride or the salt, okay, this will sense that there is a reduction in the sodium, and this will stimulate the granular cells which are present. These will secrete renin into the afferent arterioles, and then the renin is going to activate the RAAS system or the renin angiotensin aldosterone system. Okay, so if there is low perfusion, so that means there is low sodium because the pressure is low, the macula densa is sensing it, and the renin is getting secreted. Renin is going to activate the angiotensin 1, that will activate the angiotensin 2, finally the aldosterone, and then the physiology is maintained. Okay. Acid-base balance. So I want all of you to just maybe have a paper and pen. Okay, take it easy. There is actually, this is not very confusing. Okay, you will be given various kind of scenarios, but once you have your fundamentals clear, any kind of scenario that they give you, you will be able to answer that. Okay, so normal, we spoke about the normal arterial pH. It is 7.35 to 7.45. We must have that idea. They will give you in the exam also whether it is low or normal, but it is always good because sometimes they may not. Okay, so you have an idea what a normal pH is, 7.35 to 7.45. PaCO2 is 35 to 45 millimeters of mercury, and bicarbonate is around 22 to 28 millimoles per liter. So then there is one Henderson-Hasselbalch equation which we use to calculate if the patient has received proper compensation or not by the kidneys and the lungs. So this is the formula for that. This is not usually required in the exam, but you must know that this Henderson-Hasselbalch equation is there. Respiratory acidosis. So there is a mnemonic of Rome, R-O-M-E. So in a respiratory condition, if it is respiratory acidosis or respiratory alkalosis, the pH is going to move opposite. So if it is acidosis, then the CO2 will go up, okay? And because it is acidosis, the pH is going down. So CO2, the respiratory element, is going up and the pH is going down. On the other hand, respiratory alkalosis, the pH is going up, CO2 is going down. So if your question mentions that the pH is high and the CO2 is low, if they are in the opposite direction, then you have to understand that they're talking about a respiratory condition, a respiratory alkalosis condition. So CO2 increase is acidosis and reduction is alkalosis. Okay. Metabolic acidosis, so ME means metabolic system will move equal to the pH. Okay, so if metabolic, what are we measuring it with? Bicarbs. So if the bicarbs are going up, that means the pH is also going up. So they're moving up at the same time. Okay, metabolic alkalosis, pH is going up, bicarbs are going up. Metabolic acidosis, pH is going down, bicarbs will also go down. Okay, so if the respiratory is the primary thing, then the kidneys will pick up, compensate. If the kidneys are the primary organ which is causing this imbalance, then the lungs will compensate. So the compensation is by each other. What is an ion gap? An ion gap is the difference of sodium, which is the positively charged ion, and sum of chloride and bicarbs. Okay, so this is the anion gap, and it is normally between 8 to 12. And there is an increased anion gap because of these conditions. And the mnemonic to remember this is mud piles. Okay, so methanol, uremia, diabetic ketoacidosis. P was initially for paraldehyde, but that is now obsolete. So we have paracetamol and propylene glycol. Then iron and isoniazid is the I. L is for lactic acid. E is for ethylene glycol. And S is for salicylates. So when a question is given to you, okay, when they're asking you analyze, then you are supposed to first see the pH. Okay, see whether the pH is acidotic, so it is less than 7.35, or it is alkalotic, whether it is more than 7.45. So this basic thing has to be clear. Low pH is acidotic, high pH is alkalotic. This has to be clear. Okay, and the normal, of course, we all know. Then you see the CO2 value. If the CO2 is matching, okay, like I said, our respiratory is opposite. So if the CO2 is high and the pH is low, then we are dealing with respiratory acidosis. If the CO2 is low and pH is high, then it is alkalosis due to the CO2. So it is respiratory alkalosis. If you're not able to make out, or if the carbon dioxide is in a compensated condition, then move to the bicarbs, okay, and see if the pH is high and the bicarbs are high, then you're going to deal with metabolic alkalosis. pH is low, so acidotic, and low bicarbs. So bicarbs are alkaline. If they are low, that means it is acidotic. Low pH, acidotic. Low bicarb, acidotic. So we are dealing with metabolic acidosis. And the compensation will come from the other system. So if it is the kidney which is causing the metabolic or respiratory condition, metabolic acidosis or alkalosis, the respiratory system will bring in the compensation, and the other way around too. Okay, we spoke about the anion gap, and most of the classic causes of respiratory acidosis are COPD, opioids, and sedation. Respiratory alkalosis is seen in pulmonary embolism, anxiety, pregnancy, and salicylates. Metabolic acidosis, where there is increased anion gap, so that is seen in diabetic ketoacidosis, lactic acidosis, uremia, and toxins. Then metabolic acidosis is seen in diarrhea and RTAs. Then metabolic alkalosis is, we discussed yesterday about hypocholoremic metabolic alkalosis. So that is in vomiting, diuretics, and hyperaldosteronism. Just a minute. Okay, in pregnancy, the ABG will show you a compensated respiratory alkalosis, which is normal for pregnancy. The pH is slightly alkaline. The PaCO2 is around 28 to 32 millimeters of mercury, which is lower than in a normal adult. Bicarbonate is around 18 to 21 millimoles per liter, which is also lower than seen in a normal adult. And this is all due to progesterone stimulated hyperventilation and compensated by the renal bicarbs excretion mechanisms. Okay, so like I told you yesterday also, RCOG is now modifying its questions. Okay, so in the previous exam, there was a graph which was given. Okay, and they had given that this is normal pH, and they had marked a cross over here and asked that what is this condition indicating. So they had given a scenario and given a graph. So this is known as the Davenport diagram, and this was something new for the exam going batch. So obviously, now it is important that you all know about the Davenport diagram, and you know that the normal pH is right in the center, where they will give you a star, and then they will mark a cross here and ask you what is the condition indicating. So on the left side of this table of this diagram is the acidosis, okay, and on the right side it is alkalosis, okay, because this is the pH. Lower pH is acidosis, higher pH is alkalosis. And on the Y plot, it is the bicarbs, okay? So if the cross is marked in the upper left quadrant, okay, that is indicating respiratory acidosis. Then similarly, if it is in the lower left quadrant, then it is metabolic acidosis. If it is in the right upper quadrant, it is metabolic alkalosis, because this is alkalosis and the bicarbs are going up, okay, on the Y line, it is the bicarbs. So this is metabolic alkalosis, and on the lower right side, if it is there, then this is respiratory alkalosis. This is just an algorithm to tell you how to decide whether it is metabolic or respiratory. But this Davenport diagram is something new and something that you should all be aware about. Okay, just recalling what we just discussed. Normal GFR is 125 milliliters per minute. The proximal convoluted tubule, it will reabsorb 67% of the electrolytes and most of the sodium and water. Loop diuretics like sodium, potassium, and ClCl, chloride 2, so NKCC2, are present in the thick ascending loop, and thiazides are going to act on the distal convoluted tubule, and they will help in the sodium chloride mechanism, homeostasis. Aldosterone is going to act in the collecting duct. The ADH is going to open up aquaporin 2, and this is also going to act in the collecting duct. Normal pH is 7.35 to 7.45. So if it is not given in the exam, please don't forget that. Mud piles is the mnemonic for increased anion gap acidosis. Anion gap is the difference of sodium and chloride plus bicarbonate. Okay, so chloride plus bicarbonate together and subtracted from the concentration of sodium. So that is anion gap, and the normal one is 8 to 12. Okay, pregnancy is a state of compensated respiratory alkalosis. This is very, very important. Okay. So what are the changes which are happening in the kidneys in pregnancy? The GFR is increasing by 50%, and it is peaking in the first trimester. The renal plasma flow is increasing by 60 to 80%. The filtration fraction remains unchanged. Kidney size is also increasing by 1 to 1.5 centimeter. There is calicial and ureteric dilatation because of progesterone and pressure on the ureters with the uterus. So there is retrograde pressure, and therefore there is ureteric dilatation. This dilatation, whether in the ureter or in the kidney, is seen more on the right side because the uterus has a tendency to have dextrorotation. Okay, that is why preferably left lateral position. Okay, because it is already dextrorotated, you should lie on the left lateral position. Okay, so right is more likely to have hydronephrosis or hydroureter because of dextrorotation of the uterus, and also because on the left side the sigmoid colon is protecting the left ureter. And this predisposes to ascending UTI and pyelonephritis. Serum creatinine is reduced to 45 to 55 micromoles per liter, and serum urea is also going to fall. Bicarb is reduced to around 18 to 21 millimoles per liter. This is because they are compensating for the respiratory alkalosis. So glycosuria is commonly seen in pregnancy. The increased GFR by 50%, increased GFR is going to exceed the tubular reabsorption capacity. So there is more which is going into the nephron than the reabsorption capacity of the nephron. And up to 50% can have intermittent glycosuria, and therefore glycosuria is not a criteria for diagnosing diabetes in pregnancy. Proteinuria less than 300 milligrams per 24 hours is normal in pregnancy. If it is more than 300 milligrams in 24 hours and there is hypertension also, then we call it as preeclampsia. The PCR more than, that is protein creatinine ratio, is more than 30 milligrams per millimoles. This is abnormal. Uric acid will increase in preeclampsia because of impaired tubular secretion, and this is a marker for severity of preeclampsia. In renal system, we see physiological hydronephrosis, and like we said, it is going to be more on the right side than on the left, and the differential diagnosis for hydronephrosis on the ultrasound. So first will be physiological, okay? Then you move on to pathological, maybe a calculi or whatever. Bladder is pushed up by the uterus and it predisposes to frequency and also UTI because of the glycosuria and because of the pressure on the bladder. So again, right side is seen more than the left side. You see hydronephrosis and hydroureter more on the right side because of dextrorotation of the uterus. And to relieve that, you always advise left lateral position. So left lateral position is important for the cardiac output also, the venous return, and also to prevent hydronephrosis. So the GFR increases by 50% and it peaks in the first trimester. The renal plasma flow increases by 60 to 80%. Creatinine drops to 45 to 55 micromoles per liter. Urea concentration also drops. Glycosuria is common, but it is not diagnostic of diabetes. Right side hydroureter hydronephrosis is more common than the left side. There is increased risk of UTI and pyelonephrosis in pregnancy. Proteinuria of less than 300 milligrams in 24 hours is considered normal. If it is more than 300 milligrams in 24 hours and also associated with hypertension, then it is preeclamptic condition. Uric acid is increased in preeclampsia and it is a marker for severity of preeclampsia. Okay, a little bit about the GI and hepatic physiology. So the motility, because of progesterone, the motility of the gastrointestinal tract is reduced. There is smooth muscle relaxation, there is delayed gastric emptying, and constipation is a common symptom seen in pregnant women. So because there is increased transit time. So there is a lot of reflux and GERD or GORD, because in the UK we spell esophagus with O. Okay, so GORD is common. There is lower esophageal sphincter tone and it is reduced in pregnancy because of progesterone. There is increased bile cholesterol, and so therefore gallstones can form in pregnancy. There's an increased risk of gallstones. Nausea and vomiting of pregnancy, we had discussed a little bit yesterday. This happens in 70 to 80% of pregnancies. It peaks at 9 weeks and settles by around 16 to 20 weeks. Hyperemesis gravidarum is when there is severe nausea, vomiting of pregnancy with electrolyte upset. And the cause of this nausea and vomiting of pregnancy is beta HCG level. which will peak at around 9 to 11 weeks. And we had discussed that in hyperemesis gravidarum, the electrolyte imbalance that we see is low sodium, low potassium, and low urea. Okay, so this is particular in hyperemesis gravidarum. Liver changes that we see, the liver size and blood flow is unchanged. Albumin is decreased because of hemodilution. Alkaline phosphatase. So as far as the liver enzymes are concerned, the ALT, AST, and gamma-glutamine transminase remain unchanged, while the alkaline phosphatase increases 2 to 4 times. And this is not from the liver. Okay, so this is when you're doing an LFT, you will have high ALP, but that is because of the contribution of the placental alkaline phosphatase. Bilirubin remains unchanged. Fibrinogen is increased. Okay, it is an acute phase reactant and it will increase even later. Gallbladder, there is increased fasting volume. The emptying is reduced and there is stasis of bile inside the gallbladder, so it predisposes to stone formation. Intrahepatic cholestasis of pregnancy, there will be patients coming with pruritus of the palms and soles and raised bile acids. We discussed the diagnostic cutoff for intrahepatic cholestasis of pregnancy is 19 micromoles per liter of bile acids. So if it is less than that, then we're not going to call it intrahepatic cholestasis of pregnancy. Between 19 to 40, it is mild intrahepatic cholestasis of pregnancy, and the background risk of stillbirth is equal to the normal population. Between 40 to 99, the risk of stillbirth is as much as the background population till 38 to 39 weeks. Therefore, if a patient has bile acids in this category, then you will plan their delivery between 38 to 39 weeks. If, however, the bile acids are more than 100 micromoles per liter, more than or equal to 100, then the risk of stillbirth is increased, and it is in these patients that you must plan delivery by 35 to 36 weeks. What happens in preeclampsia? There's something called as HELP syndrome. So hemolysis, elevated liver function test, and the platelets are low. Okay, so this is diagnostic of HELP syndrome. So because of the progesterone, the GI motility is reduced, and symptoms like reflux, GORD or GERD, and constipation are common. Nausea and vomiting of pregnancy is beta HCG driven. It peaks at 9 weeks. The liver size and the blood flow to the liver is unchanged. Albumin is reduced. There is hemodilution. Alkaline phosphatase is increased by 2 to 4 times, and that is not from the liver. It is from the placenta. The other enzymes remain unchanged in pregnancy. Bilirubin is unchanged in pregnancy. There is an increased risk of gallstones because of cholesterol and also because of stasis in the gallbladder, again because of progesterone. And HELP is a preeclampsia variant. There's hemolysis, elevated liver enzymes, and low platelets in HELP syndrome. Talking about the coagulation factors and hematology in pregnancy, I think one of you had sent a query even in the Telegram group today. So I hope this will solve your query. So RBC mass increases by around 20 to 30%, and plasma, we had discussed, increases by 45%. So there is hemodilution. Normal hemoglobin ranges in pregnancy. In the first trimester, it should be more than or equal to 110 grams per liter. In the second trimester, it should be more than or equal to 105 grams per liter. In postpartum period, it should be more than or equal to 100 grams per liter. WBC will increase. These are mainly going to be neutrophils. It is going to be 6 to 16 into 10 raised to power 9 per liter, and this is normal. Platelets remain unchanged, or they may fall because of either hemodilution or gestational thrombocytopenia. Iron requirement is increased, and iron deficiency is commonly seen in pregnancy. Folate requirement will double. There is that is why you have to supplement with 400 micrograms preconceptionally or periconceptionally. B12 is mildly reduced because of the hemodilution, and because of the fibrinogen, the ESR is increased. Okay. So as far as the clotting factors are concerned, the increased factors are fibrinogen, factor 7, factor 8, factor 9, factor 10, factor 12, and von Willebrand's factor. Then PAI1 and PAI2, which are from the placenta, they will also increase. The D dimer also increases in pregnancy. So therefore, in pregnancy, it is not a very useful marker for DVT, okay, or any kind of pathology. So D dimer is normally also increased. Platelets may remain normal or may slightly reduce. ESR is increased because of fibrinogen. So in all, because of the increase in procoagulant factors, the net effect is that the pregnancy is a hypercoagulable state and there is an increase in risk of VTE. Okay, so the VTE risk is 5 times more than the normal population, and postpartum it is around 10 to 20 times more. Okay, it is around 20 times. So pregnancy is a hypercoagulable state. All clotting factors except for factor 11 and 13 increase. Fibrinogen will increase around 2 times, and factor 7 will increase 10 times. Factor 8 will increase, and von Willebrand factor will also increase. Okay. So pregnancy is a hypercoagulable state. All clotting factors except factor 11 and 13 will increase. Fibrinogen will increase by 2 times. Factor 7 increases 10 times. Protein S, which is actually an anticoagulant, will reduce. Protein C remains unchanged. Antithrombin is unchanged. PAI1 and PAI2 will increase. So fibrinolysis is reduced. The result overall is an increase in VTE risk around 5 times, and it increases around 20 times postpartum compared to the normal population and compared to the antepartum period. Okay, and this high risk is in the first 6 weeks after delivery. The D dimer is raised physiologically, so therefore it is not a very useful marker to rule out VTE in pregnancy. And prothrombotic adaptations protect the body from PPH. So why is pregnancy in a hypercoagulable state? So that there is no PPH. And we recommend low molecular weight heparin prophylaxis if a patient has high risk factors for VTE. Okay. So procoagulants, all factors are increased except for factor 11 and factor 13. Protein S, which is an anticoagulant, it will fall down. Fibrinogen levels will increase, it will develop. And D dimer level has limited utility in pregnancy because it is increased physiologically. So pregnancy is a hypercoagulable state. All factors except factor 11 and 13 will increase. Fibrinogen will increase 2 times. Factor 7 will increase 10 times. Protein S is an anticoagulant. It will drop. Antithrombin and protein C remain unchanged. The PAI1 and PAI2 from the placenta will increase. So they reduce the fibrinolysis. VTE risk is increased around 5 times in the antenatal period and 20 times in the postpartum period. D dimer has limited utility. Hemoglobin cutoffs in the first trimester is 110, second trimester 105, and postpartum 100 grams per liter. Okay. So we will move on to the SPAs for the second hour. Okay. Loop diuretics like furosemide act on which transporter? Does it act in the DCT on the sodium chloride symporter, whether it is acting on the thick ascending limb in the sodium potassium CC2, whether it is acting on the epithelial sodium co-transporter in the collecting duct, or on the aquaporin 2 or on SGLT2 in the proximal tubule. So where do the loop diuretics act? So they are acting on the thick ascending limb in the sodium potassium chloride 2 blocks, okay, in the co-transporters called sodium potassium 2 Cl. Thiazides will block the sodium chloride transporter in the DCT. Amiloride will block the ENAX, and ADH acts via the aquaporin 2, and desmopressin will block the aquaporin 2. The anion gap, how is it calculated? Is it the difference of sodium and the sum of chloride and bicarbonate ions? Is it the sum of sodium and potassium minus the chloride ions? Is it chloride ions minus sodium and potassium bicarb sum? Is it sodium minus the chloride? Is it bicarbonate minus the sodium plus chloride? So what is the answer? It is sodium minus the sum of chloride plus bicarbonate. Okay, so anion gap is defined as the sum, is the difference between the sodium ions and the sum of chloride and bicarbonate ions, and the normal is 8 to 12 millimoles per liter. The mnemonic in which conditions or which drugs will increase it is mud piles. So it is methanol, uremia, diabetic ketoacidosis, paracetamol, isoniazid, lactic acidosis, ethylene glycol, salicylates, and normal gap acidosis is seen in diarrhea and renal tubular acidosis. GFR change in normal pregnancy, is it reduced by 50%, reduced by 20%? There is no change. It is increased by 50%, or is it increased by 100%? So GFR increases by around 50%, and it peaks in the first trimester due to increase in renal plasma blood flow by 60 to 80%. The serum creatinine will fall to 40 to 45 to 55 micromoles per liter, and the urea levels will also fall. So in a normal, non-pregnant patient, creatinine may be actually abnormal in pregnancy. So what we consider normal in a non-pregnant condition is actually abnormal in pregnancy. So that is why you have to have different parameters. Physiological hydronephrosis of pregnancy is typically left greater than right, right greater than left, bilateral symmetrical, confined to the bladder, never seen in normal pregnancy. It is right greater than left, and we've discussed it pretty often, okay, because of the dextrorotation of the uterus and protection of the sigmoid colon on the left side. So therefore, the right side will have more pressure, and that will get dilated more. This will predispose the patient to have ascending UTIs, pyelonephritis, and it is commoner on the right side. Okay, raised alkaline phosphatase in normal pregnancy is mainly due to hepatocyte damage, placental alkaline phosphatase isoenzyme, bone resorption, cholestasis, or renal impairment. So we had discussed what is it due to. It is not from the liver. So what is it due to? It is placental alkaline phosphatase isoenzyme. So it rises 2 to 4 times in normal pregnancy due to the placental isoenzyme. Okay, and also some bone contribution, but not liver disease. Rest of the liver enzymes and bilirubin remain unchanged, and a rise in any of these enzymes will suggest a pathological condition like intrahepatic cholestasis of pregnancy or HELP syndrome. Nausea and vomiting of pregnancy is most closely linked to which hormone? Progesterone, estrogen, beta-HCG, human placental lactogen, or cortisol. And I'm sure most of you will get this right. It is beta-HCG. It correlates with beta-HCG, which is peaking at around 9 to 11 weeks. And this matches the typical peak of the symptoms of nausea and vomiting of pregnancy, and conditions in which the HCG is very high, like in molar pregnancy or in multiple pregnancy, they have more severe conditions of hyperemesis and nausea vomiting of pregnancy. In pregnancy, which clotting change is correct? All clotting factors decrease, protein S increases, fibrinogen doubles, antithrombin falls markedly, and D-dimer falls. So what is the correct statement? Fibrinogen will double. So it is a hypercoagulable state. Fibrinogen will increase around 2 times, and most factors will rise. Factor 7 will increase up to 10 times, except for factor 11 and factor 13, which usually remain unchanged or minimally decrease. Protein S is a procoagulant, it will fall. It is an anticoagulant, it will fall. Protein S and antithrombin remain unchanged. D-dimer will rise physiologically. So no, it is not useful, or it has limited value to exclude BTE in pregnancy. Which natural anticoagulant decreases in pregnancy? Is it protein S, protein C, antithrombin 3, heparin cofactor 2, or all of them? Okay, so what is it? It is protein S. This is an anticoagulant whose levels are actually decreasing. So that is also adding to the hypercoagulable state. Protein S falls in pregnancy. Acquired protein S deficiency can be there, contributing to the hypercoagulable state. Protein C and antithrombin remain unchanged, and combined with the rising procoagulant levels, this is going to exacerbate the VTE risk by around 5 times antenatally and 20 times postpartum. VTE risk in the postpartum period compared with the non-pregnant state is approximately unchanged, 2 times higher, 5 times higher, 20 times higher, or 50 times higher. So we've discussed this, and it is 20 times higher, okay, according to the Green Top guideline. Why is D-dimer of limited use for diagnosing VTE in pregnancy? Because it is always low. It is physiological in pregnancy. The rise is physiological. It cannot be measured in pregnancy. It only detects arterial clots, and it is altered by folate supplements. So why is the D-dimer of limited use in pregnancy? It rises physiologically in pregnancy. Okay, so D-dimer is normally raised in pregnancy. That is why in the VTE workup, when we initially go and check the D-dimers, it is of limited use of checking in pregnancy. Okay, so the raised value, so it is losing its specificity, and the cutoff is not reliable to exclude VTE. Therefore, you have to do imaging studies like a compression ultrasound for ruling out DVT, or you have to do a CTPA or a VQ scan to rule out pulmonary embolism. CTPA 0.1, VQ scan 0.5, fetal radiation dose. All right, so we are moving into our third and final R of physiology. I will again take a short 2-minute break to have a sip of water, and then I'll get back. All right, okay. So let's move to the final section on reproductive, placental, and fetal and lactation physiology. So again, these are very, very important. A lot of it is also going to cover your clinical topics. Okay, so we're going to be discussing the menstrual cycle and the hypothalamus pituitary gonadal axis. We're going to be discussing placental physiology, fetal physiology, and fetal circulation, which I think you've already done in embryology quite a bit, but we will be redoing that in a small way. Okay, and of course, lactation physiology, and then we'll be doing the 10 SPAs. Okay, so let's talk about the menstrual cycle and the HPG axis. So it is the hypothalamus pituitary gonad axis, and the hypothalamus will release GnRH in a pulsatile manner. It releases slow pulses, that means pulses of 90 minutes. That will favor the release of FSH, and later the pulses will increase in frequency. They will become every 60 minutes, and that will favor the release of luteinizing hormone. So the FSH is going to act on the granulosa cells of the ovary, which in presence of aromatase enzyme will convert the estrogen of estradiol formation. Okay, so the theca cell is going to act on cholesterol and form the androstenedione and testosterone. That is going to transfer to the granulosa cells, and the aromatase enzyme over there is going to convert this testosterone into estradiol. So granulosa cells are under the action of FSH. The LH will act on the theca cells, which will act on the androgens, like we had just discussed, which will be the substrate for the granulosa cell aromatase. LH surge is important for ovulation, and the surge will begin 24 to 36 hours prior to the ovulation. Okay, so this is your LH curve. Okay, LH surge, the surge, that means the rise in LH is going to start to increase 24 to 36 hours prior to ovulation. And the LH peak is when this LH has reached its peak. Okay, so that is around 12 to 16 hours. Various books vary in their durations. So LH peak will be 12 to 16 hours prior to ovulation. So LH surge is 24 to 36 hours. LH peak is at the peak of the surge. Menstrual cycle, a typical menstrual cycle is of 28 days. Day 1 to 5 is the menstrual period where the woman is menstruating. Day 1 to day 13 is also the follicular phase. Okay, now in a menstrual cycle, because the menstrual cycle average is 28 days, but some can have less than that, some can have a longer cycle. So the follicular phase is variable, but the luteal phase, that is between day 14 to day 28, that is always 14 days. Okay, so that is why when you know that the ovulation has happened, you know within 14 days the menstruation is going to come. Okay, so the luteal phase is fixed. On day 14 is the average day of ovulation, and the second half of the cycle is luteal phase. So this is a diagram to show the two cell theory. The LH is acting on the theca cell. The theca cell, the substrate is cholesterol, and that will convert to testosterone. That will go to the granulosa cells. The granulosa cells will be acted on by FSH, and then the aromatase enzyme will convert the testosterone to estradiol. First half of the cycle is predominated by estrogen, okay, and this estrogen is under the secretion of FSH. Then the LH will start rising, and in the second half of the cycle, it is predominated by progesterone. Okay, so this graph is very important. So have this in mind before you answer questions on what will happen in the first half of the cycle, or they give you patient is on day 24 of her periods, of her menstrual cycle. So what is the hormone level, whether the progesterone is high, estrogen is low, estrogen high, they can give you various combinations. Okay, so this diagram is very important to solve those questions. In the follicular phase, there is a recruitment of follicles, there is increased estradiol, and therefore initially there is a negative feedback. Okay, so the estradiol will give a negative feedback to the pituitary to reduce the FSH secretion. And by day 7, a dominant follicle is selected. And once a dominant follicle is selected, the estradiol levels will start rising significantly. And once they reach a level of 200 picograms per ml, estradiol shifts to a positive feedback mechanism. Now, positive feedback mechanism is not something which is commonly seen in a human body. So this is one such condition. The other condition is when we spoke about the action potential. So the sodium ions kept coming in, and once the sodium ions had reached a particular point, they sent a positive feedback. So the voltage gated channels had opened and the sodium had come in significantly in large numbers. So similarly here, once the estrogen reaches a level of 200 picogram per ml, it will have a positive effect. Positive feedback for what? Positive feedback for LH, not for FSH. On FSH, it has a negative feedback. On LH, once it reaches 200 picograms per ml, it will have a positive feedback. So estrogen rises, there is a positive feedback to the hypothalamus, then the pituitary will release more of LH, there will be an LH surge, and that will give rise to ovulation. So now what happens in the luteal phase? The corpus luteum forms, obviously. Okay, so this is in the theca and the granulosa cells, they will form a corpus luteum. Progesterone is the dominant hormone in this period. The endometrium was hypertrophic in the first half. It will now become secretory in the second half of the cycle. Okay. Corpus luteum will regress if there is no implantation, if there's no fertilization. Then the corpus luteum will regress by day 24 to 26, and there will be a fall in the progesterone levels, and there will be menstruation. So if there is implantation, then the HCG, which is produced from the syncytial trophoblast, it will continue to maintain the corpus luteum until 8 to 10 weeks. Okay, and then the placenta takes over the progesterone production and the corpus luteum is no longer needed. Okay, so this feedback loop is very important, that estrogen can have a negative and a positive feedback, but the positive feedback is not on its regulatory FSH, it is having a positive feedback on luteinizing hormone. So two-cell theory, theca cells make androgens under the influence of luteinizing hormone, and granulosa cells will aromatize that to estradiol under the influence of FSH. And so together they are forming the estrogen. Okay. So GnRH is released in a pulsatile manner. If it is released in 90 minutes, that is in slow pulses, it will stimulate the secretion of FSH. If it is going to release in quicker pulses every 60 minutes, then it is going to stimulate the release of luteinizing hormone. FSH will act on granulosa cells and then they will produce estradiol. LH will produce androgens in the theca cells. LH surge to ovulation is around 24 to 36 hours. Luteal phase is fixed, always 14 days. Follicular phase may be variable. Estradiol switches to positive feedback when it reaches a level of around 200 picograms per milliliter. It has a positive feedback on luteinizing hormone. Progesterone is dominant in the luteal phase. Secretory endometrium is there in the post-ovulation phase, and HCG will rescue the corpus luteum. HCG secreted from the syncytial trophoblast will protect the corpus luteum until 8 to 10 weeks. Okay. About the placental physiology. So the placenta is forming from the trophoblast and the decidua basalis. On the fetal side, there are the chorionic villi. So the outer core is syncytial trophoblast and the inner core is actually cytotrophoblast. Outer side, it is syncytial trophoblast. Maternal side, it is decidua basalis with the maternal sinusoids. Type of placentation is hemochorial. So this is peculiar. This is characteristic in human placentation. So this is kind of an invasive placentation which is happening. But even though we call it hemochorial, okay, so it is blood and placenta chorion, but it is not mixing directly, okay. So there is a thin layer of the fetal endothelium which is keeping it from direct mixing of the fetal and the maternal blood. Okay, so it is hemochorial, but still not completely directly mixing. The term placenta weighs around 500 grams. It is around 22 centimeters in diameter, and the formation is by the syncytiotropoblast and fetal endothelium. So there has been a question, what is the formation of term placenta? So if you have an option of syncytiotropoblast and fetal endothelium, good, go for it. Then they asked the placental barrier at term is made by, and they give cytotrophoblast, syncytiotropoblast, fetal endothelium also, all these various options. In that, the answer, the most correct answer would be syncytiotrophoblasts, since they've asked about the placental contribution of the barrier. Okay, so the term placenta, it is, the barrier is by syncytiotrophoblasts and fetal endothelium. But if the question has asked you about placental barrier and they have given both the options of syncytiotrophoblasts and fetal endothelium separately, the single best answer is going to be syncytiotrophoblasts. Functions of the placenta, we all know, is gas exchange. It helps in passive diffusion. Nutrient transport, of course, it can be active and facilitated. Hormone production, it produces HCG, human placental lactogen, estrogen, and progesterone. It acts as an immune barrier, and it also helps in waste excretion. So the fetal CO2 and urea are excreted through the placenta into the maternal system. So HCG is produced by the syncytiotropoblast. It is detectable by 9 to 11 weeks, and it peaks at around 8 to 10 weeks. It maintains the corpus luteum, which is producing progesterone, until the placenta will take over at around 10 weeks. And there is mild thyrotropic activity because the HCG shares its alpha subunit with TSH. That is why in the first trimester, there is transient hyperthyroidism, because the HCG, the alpha unit, simulates TSH, and therefore certain hyperthyroid features can step in, and those are not to be treated, okay, in the first trimester unless you are sure that this is hyperthyroidism. Clinically, beta-HCG is used for pregnancy test. It is very useful for ectopic management and in following up molar pregnancy and choriocarcinoma. Human placental lactogen, the source is again syncytiotrophoblasts. It is secreted throughout pregnancy. The function is, it is an insulin antagonist, and it can therefore predispose to gestational diabetes. Maternal lipolysis is promoted, so it spares the glucose for the fetus. Okay, so the mother is using her fat for energy, and the glucose which is present in the mother is utilized due to human placental lactogen by the fetus. Some lactogenic and somatomamotrophic activity is also there. Clinically, it drives glucose intolerance of pregnancy, which is checked by OGTT at 24 to 28 weeks. Talking about progesterone, the source is corpus luteum in the first 8 to 10 weeks, and thereafter the placenta will produce it. The substrate remains cholesterol after 10 weeks. And the function is, it is maintaining the decidua and the endometrium. It is keeping the uterus quiet. Okay, so there is myometrial relaxation. So progesterone is basically reducing GI motility and the uterine contractions also, so everything. Smooth muscle relaxation, so therefore, like we said, the GI tract, it is causing constipation, and in the renal system, it is causing ureteric dilatation. Talking about estriol, which is mainly E3, that is the main pregnancy estrogen. The source is placenta, but it requires precursors from the fetal adrenals. So the dihydroepisterone androstenone sulfate, okay, from it, this is in the placenta going to give rise to estriol or E3. Function is uterine growth, breast development, and blood flow. If there is low E3, so if you remember the quadruple markers that we were studying about, so low E3 is a marker for fetal well-being concerns. Okay, so you should know which conditions have low unconjugated estriol. So that is a marker for fetal well-being concerns. So this has also been an SBA in the past. Which hormone is a marker for fetal well-being concerns, as in it is, if a low fetal estriol is there, that means that the fetus is not doing well. Okay, so that is estriol. E3, and it is a part of the quadruple test. So it is measured for Down syndrome. HCG alpha subunit shared with TSH, FSH, LH, and beta subunit is unique to HCG, and estriol needs fetal adrenal cooperation. So the fetal adrenal is actually going to produce the precursors through which the placenta is going to convert to estriol. Okay, the hormones we have just discussed. The HCG is produced in the syncytial trophoblast, peaks at 8 to 10 weeks. Its main purpose is to maintain the corpus luteum. It shares the alpha subunit with LH, FSH, and TSH. Beta unit is specific, and it is used in pregnancy tests and also as a marker for molar, choriocarcinoma, ectopics. Human placental lactogen, again, syncytial trophoblast. It is an insulin antagonist, therefore, it is predisposing the pregnant lady to gestational diabetes. It promotes lipolysis, so the glucose in the maternal system is preserved for the fetus utilization. Progesterone released from the placenta around 10 weeks. Before that, it is released from the corpus luteum. Estriol is from the placenta. The precursor is the fetal adrenal DHEAS. It is a marker for fetal well-being. The lipid-soluble drugs cross easily via the placenta. So like warfarin and sedatives, that is why they are contraindicated, because they have teratogenic effects on the fetus. Heparin does not cross because it is a large molecule and a charged molecule. And IgG will cross the placenta. It provides passive immunity to the fetus. IgM is pentameric and it does not cross the placenta. So there's a question about how the IgG passes through the placenta, and the mechanism, the type of transport is active, but it is FcRn facilitated active transport. Okay, so if they've given you FcRn mediated active transport, then that is the correct answer. If that is not there, then you can also go in for pinocytosis if that's the answer. Otherwise, the type of transport is active. Okay, so IgG crosses by active transport. Okay, placenta is hemochorial, but there is no direct mixing of the maternal and fetal blood. HCG from syncytial trophoblast, it peaks around 8 to 10 weeks. Human placental lactogen is an insulin antagonist, predisposes to gestational diabetes. Progesterone from the placenta from 10 weeks onwards. Estriol needs fetal adrenal precursors. Alpha unit of the beta HCG is common between LH, FSH, TSH, and HCG. And that is why in the first trimester, you have transient hyperthyroidism. Heparin does not cross the placenta. Warfarin crosses the placenta. It is teratogenic. IgG crosses, IgM does not. Term placenta will weigh around 500 grams, and it is formed by the syncytial trophoblast, the placental barrier, syncytial trophoblast, and the fetal endothelium. So these are important pointers and important SBAs. So these are kind of one-liners we have presented as a recall. Okay. Fetal circulation, I think you've discussed this in anatomy also, you've discussed this in embryology also. So it should be very clear to you. Fetal circulation, it is important because it has 3 shunts. Okay. So from fetal life till birth, there are 3 shunts which are operating. The first one is the ductus venosus. So the umbilical vein is carrying oxygenated blood from the placenta to the fetus. Now, if it enters the liver, then if it goes to the liver sinusoids, etc., it will get deoxygenated immediately. And at the moment, we do not need the liver to be oxygenated well. So there is a shunting of blood via the ductus venosus. So that is your first shunt. Okay, it will bypass the liver, and the blood, oxygenated blood, will go from the umbilical vein to the inferior vena cava. Then we have the foramen ovale. in the foramen ovale, that is a gap between the right atrium and the left atrium. So this is because even the lungs are non-functional in the fetus. So therefore, the blood is shunted from the right atrium to the left atrium, so that more and more oxygenated blood goes from the left atrium, left ventricle to the entire body. Okay, so that is your second shunt. And the third shunt is ductus arteriosus. Now, the little bit of blood that has gone into the right ventricle in the developing fetus, which has entered the pulmonary circulation, it is not going to be oxygenated. So that is also shunted from the pulmonary artery to the descending aorta. This is the third shunt. This is ductus arteriosus. So there are three shunts: ductus venosus, umbilical vein to inferior vena cava. These are all preventing the blood from getting deoxygenated and reaching the left heart on priority. Then the foramen ovale, which is between the right atrium and the left atrium. The ductus arteriosus, which is between the pulmonary artery and the descending aorta. So at birth, when the baby takes his first breath, his or her first breath, there is a rise in alveolar oxygen tension. Okay, so the baby is breathing. The baby's breath contains oxygen. So the alveoli will receive oxygen and there will be pulmonary vasodilatation. When the pulmonary vasodilatation occurs, so the vascular resistance in the pulmonary circulation will decrease. So the pulmonary circulation will pull up most of the blood and take it to the lungs, and the lungs will also start oxygenating the blood. So alveolar O2 concentration will increase, causing pulmonary vasodilatation. Pulmonary venous return will increase. This will increase the blood flow in the left atrium. The left atrium, so if the left atrium pressure is more, the foramen ovale will also close. So with the first breath, the functional closure of the foramen ovale is going to happen. Then, because of the increase in the pressure in oxygen tension, there is loss of PGE2, and therefore the ductus arteriosus, which is connecting the pulmonary artery to the descending aorta, that will also close. So the shunts are all closing one by one. So the blood is now going to go into the like a normal circulation. So from the right heart to the lungs, then to the left heart, then to the entire body. So because the shunts are now closing, increase in left atrial pressure, the foramen ovale has closed, loss of PGE2, the ductus arteriosus has also closed. And once the cord is clamped, the umbilical vessels will also constrict. Now there is a question, which vessel in the fetal circulation contains highest oxygenation? And the clear-cut answer is obviously the umbilical vein, because that is carrying the oxygenated blood from the placenta. It has around 80% saturation. The next question can be, which has the lowest fetal pressure of oxygen, saturation of oxygen? So that will be the descending aorta, because already the blood has traversed the entire system. It has come to the descending aorta. And also there is shunting of blood from the pulmonary artery to the descending aorta via the ductus arteriosus. So that carries the minimum level of saturation of oxygen in the fetal circulation. Okay. So at birth, there is functional closure of foramen ovale. Anatomical closure is around 3 months, and it can sometimes remain patent, so that will be pathological. Then again, ductus arteriosus, the functional closure is between 24 to 72 hours, and its remnant in the adults is the ligamentum arteriosum. Ductus venosus will also close within days of birth, and it gives rise to the ligamentum venosum. So this is in brief about the fetal circulation, and it is very important because a lot of questions are asked, and it is not so difficult. So don't get confused. And if you can see, this has a 5-star weightage. Okay, so this is very, very important. So fetal hemoglobin is alpha-2, gamma-2 chains. Adult hemoglobin has alpha-2, beta-2 chains. There is higher oxygen affinity, so the oxygen dissociation curve is shifted to the left. Okay, it is predominant from fetal age of 8 weeks to birth. It switches to adult hemoglobin 6 months postnatally, but adult hemoglobin also begins to form in fetal life, but it completely takes over in the 6 months postnatally. Persistence is due to hereditary presence of hemoglobin F or in thalassemias. Okay. Fetal lung maturation, the surfactant is produced by around 24 weeks from type 2 pneumocytes, and it is stored in what we call lamellar bodies. So that is another SPA. The LS ratio of more than 2:1 indicates that the fetal lungs have matured. This happens around 32 weeks. Presence of phosphatidylglycerol means that the fetus is mature. This happens around 35 weeks. Antenatal corticosteroids between 24 to 34 weeks will accelerate the maturity of the fetal lungs. Fetal kidneys begin to produce urine around 10 weeks, and they contribute to the amniotic fluid around 16 weeks, and they are the most important contributor to the amniotic fluid by 18 weeks. Okay, so beginning at 10 weeks, contributing at 16 weeks, major component at 18 weeks. Okay, so this is important as far as fetal kidneys are concerned. Fetal swallowing and gastrointestinal fluid recycling also maintains the amniotic fluid volume. So again, there are 3 shunts, which is ductus venosus from the inferior vena cava to the from the umbilical vein to the inferior vena cava. Foramen vein is from the right atrium to the left atrium. Ductus arteriosus is from the pulmonary artery to the descending aorta. It develops from which aortic arch? Question for you, answer in the group. All right. Okay. So yesterday somebody had asked us about alpha thalassemia. So how is alpha thalassemia diagnosed? So it is not diagnosed by HPLC, but if suppose the HbA2 is normal, you have anemia, and the HPLC is also coming out to be normal, then you deduce it to be alpha thalassemia, and then you will go in for genetic testing. Okay, so that is the answer for that. Okay, fetal physiology and circulation, quick recall. 3 shunts, ductus venosus, foramen ovale, and ductus arteriosus. Ductus venosus will bypass the liver. Foramen ovale is bypassing the lung. Ductus arteriosus is also helping in bypassing the lungs because it is shunting the blood from the pulmonary artery to the descending aorta, because the liver and lungs are not functional at that time. Umbilical vein has the highest saturation of oxygen in the fetal circulation. Hemoglobin F, fetal hemoglobin is alpha 2, gamma 2, and there is a left shift of the oxygen dissociation curve so that the fetus can utilize as much maternal oxygen as it can and as it requires. Surfactant is from type 2 pneumocytes. It is stored in the lamellar bodies. LS ratio of more than 2:1 is sign of maturity, which comes around 32 weeks of gestation. Steroids are given for lung maturity between 24 to 34 weeks. Fetal urine starts at 10 weeks, contributes to the amniotic fluid at 16 weeks, and becomes the major component of amniotic fluid at 18 weeks. Okay, talking about lactation, it is very important. Okay, these days they are asking questions about the anatomy of the breast also. We're going to be doing a YouTube video on that. And lactation physiology is important. They have a lot of questions on the components of the colostrum and the breast milk. So those are very important. So let's just discuss the key points. The estrogen helps in ductal growth, and progesterone helps in alveolar growth or the lobular growth. And in pregnancy, both are increasing. So there is a complete breast development. Milk production is also in stages. That is, lactogenesis is in stages. Stage 1 is when the colostrum is forming, and it starts as early as 16 weeks. So between 16 to 22 weeks, colostrum production starts forming. Okay, the colostrum production starts. In stage 2, it is 30 to 72 hours postpartum. This is where the true milk will come in, okay? And the trigger for this formation is progesterone withdrawal after placental delivery. Stage 3 is maintained by demand, okay? So if you are feeding the baby, the more milk is forming. So it is supply and demand. If you stop feeding, then the lactation can also stop. So it is supply and demand, that is stage 3. Prolactin is produced by the anterior pituitary and it increases during pregnancy under the influence of estrogen. So estrogen is the driving factor for increasing prolactin production by the anterior pituitary. And it has, the prolactin, as we all know, has a negative feedback from dopamine, which is also called prolactin inhibiting factor. And this drives the milk synthesis. So you have two hormones. You have prolactin and you have oxytocin. Prolactin is helping in synthesis and oxytocin is helping in ejection. So prolactin is produced from the anterior pituitary. Oxytocin is produced from the posterior pituitary. Function of prolactin is milk synthesis. Oxytocin is helping in milk let down or milk ejection. The trigger for prolactin is suckling, and the afferent neural stimulus will go and stimulate release of more prolactin. And estrogen during pregnancy will help the prolactin to increase. Regulation is by dopamine. It is under inhibitory effect of dopamine. It has hypothalamic tonic inhibition, and dopamine agonists like bromocriptine and cabergoline are used to suppress lactation or treat prolactinomas. Suppresses GnRH. So that is why if a lady is exclusively breastfeeding, okay, and it is 98%, they say, if it is 98% exclusively breastfeeding and she is amenorrheic in the first 6 months postpartum, the lactational amenorrhea method of contraception is very, very effective. It is around 98% effective, okay. Let's move to oxytocin. It is from posterior pituitary. Trigger is again suckling at the nipple or even the sound of the baby crying. This is known as a conditioning reflex, or even the slight thought of the baby, okay? So working mothers, when they're going to work, okay, just the thought of the baby also helps in release of oxytocin, and there is milk ejection at that time, even though the baby is at home. Mechanism, it contracts the myoepithelial cells around the alveoli and it squeezes the milk into the ducts and through the ducts into the nipple. It also causes uterine contraction. So it aids in involution. That is why breastfeeding is actually promoted, okay, because breastfeeding will promote involution and it will also reduce chances of PPH. And it is a synthetic form is syntocinon, which is used in active management of third stage. Okay, so estrogen is going to help in the ductal growth, progesterone in the alveoli growth, and stage 2 lactogenesis is because of progesterone withdrawal. Okay, again, we've discussed about the oxytocin, which is released from the posterior pituitary. It also causes uterine involution. Now, colostrum. So day 1 to day 3, you have the colostrum, which had started being produced from 16 weeks onwards. Okay, this is a yellow, thick fluid, and it is very rich in proteins and secretory immunoglobulin A and lactoferrin. So the most abundant protein in colostrum is secretory immunoglobulin A. Most abundant whey protein in the colostrum is lactoferrin. These have been SPAs. Colostrum has low fat and lactose, and it is very small in amount. Okay. Then after 72 hours, 48 to 72 hours, there is mature milk formation, and this milk has higher fat and lactose content. It has lower protein content, and the most abundant protein in mature milk is alpha lactalbumin. Again, another SPA. Okay. So please take care of this. Foremilk is low in fat and hind milk is high in fat. And so therefore, we always recommend the patients that they should empty the breast so that the foremilk and hind milk benefit reaches the baby. Now, about lactational amenorrhea method, it is 98% effective if the lady is exclusively breastfeeding, if she is amenorrheic, and in the first 6 months of delivery. So first 6 months of delivery, if she's exclusively breastfeeding and she has not resumed her menstrual cycles, then this method is 98% effective. Prolactin suppresses GnRH, and therefore there is no ovulation. That is why it is an effective method of contraception. The drugs contraindicated in breastfeeding are amiodarone, chemotherapy drugs, ergots, lithium, methotrexate. These are the most commonly asked questions. So these have been mentioned. This table is important because a lot of questions have asked which is the predominant carbohydrate, which is the predominant protein. Okay, so this table is important, and please take a screenshot. Okay. Okay, so synthesis versus ejection. Prolactin from the anterior pituitary is synthesizing or making the milk, whereas posterior pituitary releases oxytocin for milk letdown or ejection of the milk. Again, some recalls. So estrogen helps in ductal growth, progesterone in the alveolar growth or the lobular growth. In pregnancy, both of them are there. So it is a entire breast is developing. Stage 2 lactogenesis is due to progesterone withdrawal. Prolactin is synthesized in the anterior pituitary, and it helps in milk formation or milk synthesis. Oxytocin is from the posterior pituitary. It helps in milk letdown or milk ejection. Colostrum is thick, yellow, high in proteins and secretory immunoglobulin A. Mature milk is increased in fat and lactose. Lactational amenorrhea method is 98% effective contraception if the patient is exclusively breastfeeding, she's amenorrheic, has not resumed her menstrual cycles in the first 6 months postpartum. Prolactin suppresses GnRH, therefore there is no ovulation, and this is the mechanism of action of lactational amenorrhea method. Dopamine is a prolactin inhibitor. It has an inhibiting effect on prolactin secretion. Okay, so we are going to do some quick SPAs and on this last R. And GnRH is secreted in a pulsatile manner. Fast frequency pulses preferentially stimulate FSH, LH, prolactin, TSH, and oxytocin. So for those who've joined us late, GnRH is released in a pulsatile manner, okay? And it can have pulses of 90 minutes. Pulses of 90 minutes and pulses of 60 minutes. Fast frequency pulses, that is quick GnRH pulses, are going to stimulate LH, okay? And slow frequency pulses, which are pulses every 90 minutes, are going to stimulate FSH. Yes, I'm right. Okay, so fast GnRH pulses, that is every 60 minutes, will favor LH release, and slow pulses every 90 minutes will favor FSH. And continuous GnRH will desensitize the pituitary, and this is the basis of agonist therapy, GnRH agonist therapy, to down-regulate, and then they will start the artificial reproductive treatment. Luteal phase of the menstrual cycle is variable in length, always approximately 14 days, always 7 days. It is dependent on the FSH levels, and it is absent in ovulatory cycles. So we have discussed this. The luteal phase is always 14 days, and the follicular phase may vary. So in anovulatory cycles, it is follicular phase, which is prolonged, and thereafter, once the luteal phase happens, it is only 14 days. According to the two-cell theory, theca cells produce dash under the influence of dash. So, is it estradiol and FSH? Is it androgens and LH? Is it progesterone and FSH? Inhibin and LH, or estradiol and LH? So, according to the two-cell theory, theca cells will produce androgens under the influence of LH. Okay, so we've discussed the two cell theory also. So LH is acting on the theca cells, and theca cells are using cholesterol as the substrate and then producing testosterone and androstenedione. This is going to go to the granulosa cells where the FSH is going to act via the aromatase enzyme and convert testosterone to estradiol. Okay. HCG is produced by which cells? Is it the cytotrophoblast, syncytotrophoblast decidua, fetal adrenals, or the corpus luteum? So it is the syncytotrophoblast. It is produced by them and it is detectable around day 9 to 11, peaks around 8 to 10 weeks, maintains the corpus luteum until the placenta takes over around 10 weeks of gestation, and it shares its alpha subunit with LH, FSH, and TSH. This is also a frequently asked question. Human placental lactogen primarily acts as a insulin sensitizer, insulin antagonist, thyroid stimulator, vasoconstrictor, or anticoagulant. So we have discussed that human placental lactogen predisposes to development of gestational diabetes. So this is a insulin antagonist, okay? It promotes maternal lipolysis and it spares the glucose for the fetus. So there's more glucose present in the maternal circulation, and this is predisposing to the diabetogenic state of pregnancy. And hence, OGTT screening is done at 24 to 28 weeks. When is OGTT screening done early in pregnancy? It is done when the previous pregnancy, also the patient had gestational diabetes. So those are the patients that you will call at booking only. You will tell them to come early for OGTT. Okay. Estriol synthesis in pregnancy depends critically on the maternal ovary, fetal adrenal DHEAS, corpus luteum, maternal liver only, or cytotrophoblast. So I'm sure all of you know the answer. The precursor is important, and that is from the fetal adrenals, DHEAS. So estriol production, that is E3, is requires fetal placental unit, that is the fetal adrenal DHEAS. This will go to the fetal liver, undergo hydroxylation, come to the placenta, undergo aromatization and form estriol. Low estriol reflects fetal compromise, and it is one of the components of the quadruple test. So if you remember, high, low, low. So estriol was low in Down's syndrome and Turner syndrome as well. Which fetal shunt connects the pulmonary artery to the descending aorta? Ductus venosus, foramen ovale, ductus arteriosus, umbilical vein, or coronary sinus. So 3 shunts: ductus venosus, foramen ovale, and ductus arteriosus. So which fetal shunt is from the pulmonary artery to the descending aorta? It is the ductus arteriosus, okay? So ductus arteriosus is shunting blood from the pulmonary artery to the descending aorta, so it's bypassing the lungs. Ductus venosus is bypassing the liver, and foramen ovale shunts the blood from the right atrium to the left atrium so that there is minimal circulation going into the pulmonary circulation. And then all of these 3 will close after birth, okay? And from which aortic arch is the ductus arteriosus formed is your homework for today. Which fetal vessel carries the most oxygenated blood? Is it the umbilical artery, umbilical vein, descending aorta, pulmonary artery, or the superior vena cava? So again, we had discussed this in detail. It is very, very important, a very frequently asked question. So the most oxygenated blood in the fetal circulation is in the umbilical vein. It carries around 80% saturation, and this is from the placenta to the fetus, most oxygenated fetal blood vessel. Umbilical arteries will carry deoxygenated blood from the fetus to the placenta. So please do not get confused on this aspect. Fetal hemoglobin differs from the adult hemoglobin in that it has a right shifted oxygen curve. It has a left shifted oxygen curve. That means it has higher affinity for oxygen. contains 2 beta chains, binds 2,3-DPG more strongly, or it cannot bind oxygen. So even if we don't know the answer, we know that nature has made the mother and baby such that the mother is going to give oxygen freely to the fetus. So the fetal hemoglobin is also such that it will take oxygen from the mother. So when it is taking oxygen from the mother, that means the oxygen dissociation curve is shifting to the left. Okay. So hemoglobin, fetal hemoglobin is alpha 2, gamma 2. It has higher oxygen affinity, and the oxygen dissociation curve shifts to the left. The gamma chains, they bind to 2,3-DPG poorly. Okay. So this helps in the fetal extraction of oxygen from the maternal blood across the placenta, and it can predominate until 6 months postnatally, and thereafter the adult hemoglobin will take over. Which hormone is responsible for milk ejection or the letdown reflex? Is it prolactin, oxytocin, estrogen, progesterone, or human placental lactogen? Again, we've discussed this in detail. So there are 2 hormones. We have prolactin and we have oxytocin. We have one from the anterior pituitary, one from the posterior pituitary. We have one which is synthesizing the milk and one which is ejecting or letting down the milk. So this is prolactin, and the one which is ejecting from the posterior pituitary, it is oxytocin. Okay, so oxytocin released from the posterior pituitary, it will contract the myoepithelial cells, cause milk ejection and letdown. Prolactin is from the anterior pituitary, and it is involved in milk synthesis. So prolactin makes it, oxytocin ejects it. So let's just quickly go through everything that we've discussed and the high yield points in our discussion. So sodium, potassium, ATPase, 3 sodiums out, 2 potassiums in. Okay, very, very important for maintaining the resting membrane potential, and therefore the action potentials as well. Cardiac plateau is due to the L-shaped calcium channels. So this is due to the calcium influx. S1, heart sound. So first heart sound is by the closure of the mitral and tricuspid valves or the AV valves. And the second heart sound is by the closure of the semilunar valves. Cardiac output is deduced by multiplication of heart rate into the stroke volume, and it is approximately 5 liters per minute. Mean arterial pressure is very important to diagnose whether the organs are being perfused well or not. And that formula is diastolic blood pressure plus 1/3 of the pulse pressure. And the pulse pressure is systolic pressure minus the diastolic blood pressure. Blood pressure is, the formula is multiplication of the cardiac output into the systemic vascular resistance. Again, plasma volume in pregnancy increases by 45 to 50%, peaks at 32 weeks. Cardiac output is also increasing by 40 to 50%, peaks at 24 to 28 weeks, but the maximal cardiac output is immediately postpartum, very, very important and critical period, and can be asked in an SPA. Systemic vascular resistance falls in pregnancy by around 30%. There is dilutional anemia because the plasma volume is increasing more than the red blood cell volume. Aortic cable compression is prominent after 20 weeks, and the management is 15 degrees left lateral tilt. Residual volume is not measured by spirometry, and if the ratio of FeV1 by functional vital capacity is less than 0.7, then you're dealing with an obstructive lung pathology. In the oxygen dissociation curve, the curve will shift to the right if there is increase in CO2, increase in hydrogen ions or acidosis conditions, increased temperature, and increase in 2,3-DPG. This is the Bohr's effect. It is seen at the level of tissues or in the organs where metabolism is happening. So they are rich in carbon dioxide. So when the blood comes to them, the blood will have lower affinity for oxygen. That is why it will move to the right and give off the oxygen and take the CO2, Bohr's effect. Fetal hemoglobin shifts the curve to the right. So that means it is having more affinity for oxygen. It will pick up maximum of the oxygen that it needs for its functioning. Tidal volume is increased by 40% in pregnancy. Functional residual capacity is reduced in pregnancy by around 20%. PaCO2 in pregnancy is around 28 to 32 millimeters of mercury. So that is why pregnancy is in a state of compensated respiratory alkalosis. The GFR in pregnancy is increased by 50%. Creatinine is reduced by 45 to 55 micromoles per liter. Hydronephrosis and hydroureter is likely to happen because of the pressure of the uterus on the ureters, and it is more on the right side. Glycosuria is common in pregnancy, and it is not diagnostic of diabetes. Loop diuretics act on the thick ascending loop and the sodium-potassium chloride two junctions. The thiazide will act on the sodium and chloride junctions in the DCT. The ADH will induce aquaporin 2, and that will help in absorption of water. And desmopressin will help in blocking these channels in diabetes insipidus. Anion gap, the formula is sodium ions minus the sum of chloride plus bicarbonate. Normal anion gap is 8 to 12. And mud piles is the mnemonic for raised anion gap, so in which conditions the anion gap will be increased. Alkaline phosphatase in pregnancy is increased around 2 to 4 times, but it is not from the liver, it is from the placental fraction. The rest of the liver enzymes are usually unchanged, so the ALT, AST, bilirubin will remain unchanged. And if they are high, then you have to look for some other pathology. Nausea and vomiting is linked to beta HCG in pregnancy, and it peaks at around 9 weeks. Pregnancy is a hypercoagulable state. All factors will increase except for factor 11 and factor 13. Fibrinogen levels will double to around 4 to 6 grams per liter. Protein S is an anticoagulant. It will fall in pregnancy, and therefore it is going to exacerbate the hypercoagulable state. Protein C and antithrombin remain unchanged. The VTE risk is increased by 5 times in the antepartum period compared to the non-pregnant population. And in the postpartum period, it is as high as 20 times. It can go even higher compared to the antenatal period and compared to the non-pregnant population. D-dimer is physiologically high in pregnancy. Therefore, it has limited utility in the algorithm for VTE. GnRH can have slow pulses and fast pulses. Slow pulses will release FSH. Fast pulses or increased frequency every 60 minutes will help in release of luteinizing hormone. Lutein phase is always 14 days. The two-cell theory, theca cell and granulosa cell. Theca cell is acted on by the LH. Granulosa cell is acted on by FSH. Theca cell will form the androgens under the influence of LH from cholesterol. The androgens will then move to the granulosa cells under the influence of FSH. Using the enzyme aromatase, the granulosa cells will form estradiol. LH surge is when the LH starts rising. It is due to the positive feedback of estradiol. When the estradiol levels go above 200 picograms, then there is a positive feedback and LH surge will happen, and then the ovulation will happen 24 to 36 hours from the beginning of the LH surge. HCG is synthesized from syncytial trophoblast. It peaks at around 8 to 10 weeks, and it is mainly functional to rescue the corpus luteum. And following that, the placenta takes over and starts producing the progesterone. HPL is an insulin antagonist, and it will predispose to gestational diabetes development in the pregnant lady. Estriol needs fetal adrenal DHEAS as a precursor. So that is that. Progesterone is released from the placenta from 10 weeks onwards. Fetal circulation, the three shunts are very important. Ductus venosus, foramen ovale, ductus arteriosus. Umbilical vein is the most oxygenated vessel in the fetal circulation. It has around 80% oxygen saturation. Ductus arteriosus shunts the blood from pulmonary aorta to the descending aorta. Okay, it develops from the sixth aortic arch. Okay, so that's your answer right there. Foramen ovale closes functionally at birth. Ductus arteriosus closes around 24 to 72 hours after birth and forms the ligamentum arteriosum. Hemoglobin. The fetal hemoglobin has alpha 2 and gamma 2. It shifts the oxygen dissociation curve to the left. Surfactant is produced by type 2 pneumocytes stored in the lamellar bodies. Okay, this is a recall. Prolactin is helping in synthesis of milk. It is released from the anterior pituitary. Oxytocin helps in milk letdown and uterine involution. It is released from the posterior pituitary. And lactational amenorrheic method is a very useful method for contraception, and it is 98% effective if the lady is exclusively breastfeeding, she's amenorrheic, and in the first 6 months postpartum. Okay, so even if she's amenorrheic beyond 6 months, lactational amenorrhea method is not that useful. Only in the first 6 months, completely amenorrheic and exclusively breastfeeding. All right, with that, we will come to the end of the physiology session. And I hope this has been useful for you, and that you have a lot of, it makes your things easy to understand. And looking forward to seeing you all in all our marathons, and hopefully you will be benefiting from them. So all the best, and keep studying. All right, so we'll end it now.